Yad bine Could a dollar the ending at the Nothini, the con Hyal Calpia, the con Washington, oh, Hayun Kinanish, Holnako, Nahat at a Zanskago, in Kinanish at Aldicon. Yards ehonet nidge with Ankidine, Bandale Nishodol, Anil Scoticon, in Kinanish in Skago, with An, Genoban, sea case dollar, don't Geno with in Kinahat Adolel, Dicon, Anil Scoticon. Keda wheat inigicon in Kilhas another decon than holds not the dollar could abba it but so the sindolel aro ankide in hitch also $0 could on hitch it so the sindolel decon yards ehot nenage with in hidden ehot ban sea kiss dollar don halchine don hit ho in hiina in hinsa kiss it it's the hood on hitch it so the sindi and the net then othini decon yards ehot nenage with in hinsa kiss. What's but so the sindol decon. What on hitch so the sindi and the net then Othini, Aronana decon dito. The water that we are going to have today, the food that we are going to have today, may it nourish our bodies today and each and every day. And as I prayed this morning, I prayed that all leaders that have come together, that we come together in our planning and our thoughts for our people so that we continue in a forward movement and that our prayers and everything that we have prayed for this morning will come into fruition for our people and for those who follow, and that we pray that all of the good things for our homes and our lives and back home will be sustenance and full of life. And I pray to you at this time, Holy People Creator, to allow the sun to nourish each and every one of our bodies, and the water that we drink nourish our minds and our spirits, and the food that we eat give us the energy and power to continue forward movement for our people. I pray to you at this time. Thank you.
Thank you. Before we get going, I'd like to just move into tribal introductions. And so we'll start to my left here. And Steve, if you go, please.
Yeah, Steve Kutz, Tribal Council, member of the College Tribe in Washington State, chair of the American Health Commission that represents 29 tribes and 2 urban programs in Washington State, and health director for the Squamish Tribe.
Good morning, everybody. My name is Richard Matins. I am the Executive Director for the Pamunkey Indian Tribe.
Good morning, George Thompson, Vice President of the Lac du Flambeau Band of Lake Superior Chippewa Indians.
Bonjour, good morning. Gloria Cobb, Lac du Flambeau Tribal Council Member.
Bonjour, Minisnoquin Indigenous Cause, Makwan Indun Dame, Wasawagan Indun Jaba, Stephanie Thompson, Tribal Council, Lac du Flambeau.
Really quick, to my right, he's shy here. This is David Poupart. He's our Clinical Director for Lac du Flambeau as well. Thank you.
Skookdash, DJ Carlisle, Vice Chairman of the Auction Indian Community.
Leosin Chenabo, good morning. Erminia Frias, Pascoyaki Tribe.
Sengi tamo biagini newe by kinakut or netwa budget and or how keat or the muwagri netwa bit to jongon hapu ongipe. My name is James Duranjo. I'm the governor of Santa Clara Pueblo in northern New Mexico.
Good morning, Chief Harris, Catawba Nation.
Husk Adzon Shlokia Ani Bashin Halsoda Shanalesh Ashida Ehud Adzine Sanenshlan Sherilyn Yazi, Executive Director for the Nabo Department of Health, proxy for our Honorable President, Dr. Bunigrin.
Good morning, my beautiful relatives. My name is Peter Lenkeek, Chairman of the Crow Creek Sioux Tribe, Vice Chairman of the Great Plains Tribal Chairman Association, and member of the NIHB.
OCO Corey Bunch, Dawado. Hello, everyone. I'm Corey Bunch. I'm proxying for Principal Chief Chuck Hoskin, Jr. of the Cherokee Nation.
Well, for an hour this morning, I was Mark Cruz, but somebody stole my name tag. So for now, yeah, I just want you to know what you're going to look like. Ron Allen, Chair, Jamestown Squamish Tribe.
Hachikano, my name is Crystal Williams. I represent the Coshada Tribe of Louisiana as a vice chair. I'm also representing USET. Thank you.
Shusha Tekene, Naomi Hartford. I'm a council member for Fort Sill, Chiricahua, Warm Springs, Apache Tribe.
Ashita Sheetak, Tasha Muso, Vice President, Wichita and Affiliated Tribes.
Manuite Squatchy Siam Nisjayacha, Lonnie Greninger, Vice Chairwoman for the Jamestown Squamish Tribe.
Morning, Sharon Stanfield, Chief Health Officer of Government Affairs, Cow Creek Umpqua Tribe of Indians, and Executive Committee for the Northwest Portland Area Indian Health Board.
Guadalupe Castaneda, Makah Tribal Council for the Makah Tribe.
Huklaksa, Uklukas Tutusakta, Yehach Koditch at Uts, the Dutch Kwathuik. Good morning, TJ Green, Chairman for the Makah Tribal Council.
Good morning, Brooke Sawyer, Councilwoman for the Makah Tribe.
Good morning, Nada Salaya, Council Member for Hill River Indian Community.
Tyler LaPlante, Vice Chairman, Sault Ste. Marie Tribe, Chippewa Indians.
Wacklisi, Mark Cruz, Senior Advisor to Secretary Kennedy, member of the Klamath Tribe. You'll notice I'm wearing my Portland Trailblazers tie today with hopes of good luck tonight.
Darcy Johnston, Director of Intergovernmental and External Affairs in the Office of the Secretary. Thank you.
Victor Joseph, member of the Native Village of Tanana, also the Alaska area, and the STAC chairman. With that, let's start through our opening comments. It's great being here with you all today. We want to thank HHS leadership for joining us today. The United States has a unique legal and political relationship with tribal governments established to and confirmed by the Constitution, federal laws, Supreme Court case law, and presidential orders. Born out of this relationship is the federal government's trust responsibility to protect the interest of Indian tribes and communities, including the provisions of health care to American Indians and Alaska Natives. Programs that serve American Indians and Alaska Natives people are based on the political status of tribal nations and their citizens. Secretary Kennedy has been the secretary most committed to Indian country and making improvements to Indian health. He has openly made tribes a top priority of his tenure and has traveled to Indian country to meeting the tribe's leaders and visiting tribal facilities. And we look forward to his continued investment in tribes. Tribes and the Secretary share the same goal, to make the health care for American Indians and Alaska Natives best in the world. And now more than ever, we need Secretary Kennedy's support to secure staffing and resources for Indian health care programs, ensuring that all of HHS is working to meet the trust and treaty obligation through government-to-government engagement, like what we are here today to accomplish. You will hear today and tomorrow about the incredible important tribal priorities which need to be budgeted and policy priorities advocated in advance to achieve our shared goals, including self-governance within HHS programs, reclassifying contract support cost and 105L lease cost, and securing continued traditional healing coverage through CMS. Together, we can make Indian country healthy again. Ms. Darcy.
Thank you, Chairman Joseph. Good morning. It is my pleasure to welcome you all to the Department of Health and Human Services for the 28th Annual Tribal Budget Consultation. My name is Darcy Johnston. I'm the Director of Intergovernmental and External Affairs. My office is the lead for tribal consultations and engagement with Indian country. I want to thank Devin Delro, Carmela Royal Bell, Elise Sparks Jackson for their work in planning this week's tribal consultation. Please reach out to them if you have any questions. On behalf of Secretary Robert F. Kennedy, Jr., I want to thank the elected tribal leaders and tribal health staff who have traveled from across the country to be here. I would also like to recognize the technical advisors who are here supporting their elected leaders, as well as the many people who are joining on the HHS live stream for the consultation. Secretary Kennedy takes seriously the obligation of our government-to-government relationship and the need to prioritize Indian health. We thank you for engaging with the department on this important consultation. At the Tribal Self-Governance Conference 2 weeks ago, the Secretary shared his 9-point plan for improving health outcomes in Indian country, which includes supporting tribal self-governance. Each year, the department provides more than $4 billion to tribes throughout the self-governance agreements. 2, investing at scale. The President's fiscal year 2027 budget includes $9.1 billion for IHS and $1.1 billion, a $1.1 billion increase from the previous year. That's an 11% boost. You'll hear more about the President's budget request from Assistant Secretary Cilarello shortly. 3, rebuilding infrastructure. The Secretary recently directed $1 billion to reduce the construction backlog at IHS. 4, strengthening the workforce at IHS. Currently, IHS is undergoing its largest hiring initiative in history. 5, modernizing the system, realigning IHS throughout robust consultation. 6, improving outcomes at birth, adding Duchenne's muscular dystrophy, DMD, and metachromic leukodystrophy, MLD, to the recommended uniform screening panel. 7, emphasizing the importance of nutrition. We rolled out the new dietary guidelines earlier this year in partnership with USDA. 8, we are confronting addiction. The Secretary co-chairs the Great American Recovery Initiative with former First Lady of North Dakota, Catherine Burgum, who you will hear from tomorrow. 9, we are investing in public health. We delivered the largest single-year investment in IHS for HIV, hepatitis C, and STI prevention and treatment. These are just some of the transformational changes that Secretary is working on, but these changes wouldn't have happened unless we heard from you all, and you need to hear from us, and what you need to hear from us. Tribal consultations, like the one today, are critical for us to hear from you all and what we can do better, where our strengths and where our resources are needed. Please continue to share with us your recommendations. I know the Secretary will continue to make tribal health and the government-to-government relationship a top priority. This consultation is a continuation of that commitment, and we thank each of you for your time and engagement this week. Thank you, Chairman Joseph, for the opportunity to provide opening remarks on behalf of the department.
Thank you. Now we'll go into our HHS budget overview, and Assistant Secretary for Financial Resources, Sharella, please welcome him. Assistant Secretary Sharella.
Good morning.
This is a very important meeting to us today, and I want to thank you for your time, but I also ask you to keep your comments short because we have a lot of leaders that would like to have some follow-up questions.
Okay.
And our schedule is tight.
I have prepared remarks, and I'll try to keep them as brief as possible.
Thank you.
So good morning, everyone, and I'm glad to be here today at the 28th Annual Tribal Budget Consultation. I am Gus Sharella. I am the Assistant Secretary for Financial Resources here. And it is nice and it is a privilege to meet all of you. This is my first meeting with tribal leaders in my role as the ASFR, and I'm looking forward to hearing your feedback and on your budget priorities. I do want to recognize my previous deputy, Katrin Shai, for her work as Principal Deputy at ASFR, and many of you may know her. Her contributions to tribal affairs are well known, and I want to wish her the best in all of her success at National Institutes of Health, and I know she wishes she could be here today with all of you. Our office always appreciates the opportunity to engage with tribal leaders through this forum to discuss your priorities in the HHS budget each year. This consultation also serves as a starting point for each year's budget process. As you know, this year we are consulting to inform the fiscal year 2028 President's budget. During this session, I will provide an overview of the fiscal year 2026 enacted budget, as well as the 2027 President's proposed budget, which was released earlier this month. We will also have time to discuss and a Q&A at the end of the session. My team has also prepared a funding crosscut, which outlines targeted funding for the tribes in fiscal year 2026 enacted and the proposed 2027 budget, which you should have received for your reference. My staff will also be in attendance for all the sessions today and tomorrow. It is a priority of the department that we are considering and applying tribal recommendations throughout the entirety of our budget formulation process. Okay, now just to give you an overview of the 2026 appropriations. HHS received a total of $126.7 billion in discretionary funding, which is $773 million above the fiscal year 2025 enacted budget. For IHS, the bill provides almost $8 billion in discretionary budget authority, which is an increase of $1 billion above the fiscal year 2025 amount. The bill provides an increase in critical operating costs, including an increase of $42 million for staffing costs of new expanded facilities, $768 million for contract support costs, and an increase of $217 million for Section 105L leases. The bill maintains indefinite discretionary funding for both contract support costs and Section 105L leases. The bill also provides smaller increases to targeted IHS programs, including tribal epidemiology centers, produce prescription pilot programs, dental health, mental health, urban Indian health, sanitation facilities construction, healthcare facilities construction, and equipment. With respect to tribal epidemiology centers, there was $39 million, which is $5 million more than in fiscal year 2025 to support the agency's overall public health infrastructure. In dental health, $260 million is allocated, which is $6 million above the fiscal year 2025 enacted amount. And this includes an increase for dental support centers and continues funding for electronic dental health records. And in urban Indian health, there's a $95 million, which is a $5 million increase above the 25 enacted budget. We are also pleased to see Congress continue to provide advanced appropriations for IHS. The bill includes a $5.4 billion in advanced funding for fiscal year 2027. Advanced appropriations will continue to provide much-needed funding stability for IHS and tribes. We saw this was critical to the start of the fiscal 2026 year and had a positive impact as IHS and tribes started the fiscal year with funding uncertainty. We are extremely pleased that IHS will continue to experience the level of stability afforded by advanced appropriations as we head into fiscal year 2027. And the fiscal year 2026 bill extends mandatory funding and authorization for the Special Diabetes Program for Indians through fiscal year 2026 at $200 million, an increase of $41 million. Additionally, the bill provides extended funding of $50 million for the first quarter of fiscal year 2027. And just to quickly go over some of the other HHS items I wanted to highlight. Congress provided funding an increase in early childhood programs in ACF, an increase of $10 million for Head Start, and an increase of $30 million for child care and developmental block grants. And we know this funding will be instrumental for expanding capacity of early child care providers across the country. In fiscal year 2026 included an increase of $3 million for ACF's administration for Native Americans. And the bill increases also funding for SAMHSA's Tribal Opioid Response Program by $5 million, which will provide increased support for tribes in responding to the opioid and substance use crisis in Indian country. The fiscal year 2026 bill also includes an increase of $2 million for ACL's Native American Nutrition and Support Services. And the bill also maintains funding for CDC's Good Health and Wellness in Indian country. Now on to the 2027 proposed budget. The budget lays out the administration's vision of making America healthy again and serves an important starting point for congressional appropriations process. The budget proposes $111.1 billion in discretionary funding for fiscal year 2027, which is, across the department, a $15.8 billion decrease below the 2026 enacted budget. But that said, the administration continues to align the budget with the Secretary's proposed reorganization and improve the efficiency and coordination of the delivery of HHS services. This includes the establishment of the new Administration for Healthy America, or AHA, which is combining programs currently administered by HRSA, SAMHSA, OASH, and portions of CDC. Additionally, the Administration for Children, Families, and Communities integrates the formerly known as ACF with the Administration for Community Living, or ACL, to promote Healthy America by supporting the economic and social well-being of families, children, and youth. As part of the budget proposal, HHS prioritizes strengthening services to tribes. Despite generally constrained funding environment, the budget proposes a number of targeted funding increases for IHS and other tribal programs. For example, the budget increases IHS funding by 13%, the largest increase across HHS, and it is the only operating division that continues to grow in this budget environment, otherwise focused on reducing federal spending. The budget at IHS requests from Congress a $9 billion total, or a $1 billion increase in discretionary funding. The request includes $265 million in current services funding to offset inflationary costs and ensure levels of direct health care services are maintained. And the budget includes $84 million to fully fund staffing of newly constructed health care facilities. Also, the proposed budget includes an indefinite discretionary appropriation for contract support costs in Section 105L lease agreements with estimated funding levels of $1.9 billion for contract support costs and $929 million for Section 105L lease agreements. Some other notable investments are $6 million to support initial costs and develop estimated costs for the delivery of health care services for the Lumbee tribe, and an additional $6 million to support delivery for health care services for the United Kituwa Band and Cherokee Indians of Oklahoma. We also propose an increase of $93 million to continue the transition to a new and modernized electronic health record system. We also propose an increase of $5 million to support key objectives of the MAHA initiative and will allow the agency to appropriately support the first ever enterprise-wide oversight body for IHS-operated hospitals. And the proposal includes a $5 million increase to address the 1993 facilities priority list. The budget also proposes $5.6 billion in advance appropriations for IHS in fiscal year 2028. Within the AHA environment, the budget includes $232 million to fund new tribal prevention innovation programs, which is a $19 million increase above 2026 enacted budget. It includes the maternal, infant, and early childhood home visiting program with an increase of $9 million above FY26 enacted, and will support the Native American Behavioral Health and Substance Use Disorder program with an increase of $80 million above the 26 enacted amount. And it will also fund the Behavioral Health Innovation Block Grant at an increase of $124 million above the 26 enacted amount. The Tribal Prevention Innovation Program will support tribes, tribal organizations, and health service providers to serve communities experiencing poor chronic disease and maternal health outcomes. The Native American Behavioral Health and Substance Use Disorder Program and Behavioral Health Innovation Block Grant will expand evidence-based practices and innovative approaches to improve access to care, and will provide funding directly to tribes to support culturally tailored mental health, prevention, and treatment efforts to behavioral health issues in Indian country. And the budget continues the Administration for Children, Families, and Communities, or ACFC, Native American Program and Services. This includes programs currently administered by ACL, which would become a component of ACFC under the proposed reorganization. The budget maintains funding for the Head Start program at $12.3 billion and funding for child care and development block grants at $8.8 billion in discretionary funds. And the budget includes an additional $7 million for tribal child support. As part of the ACFC budget, the proposal includes $40 million for the Native American Nutrition and Support Services and $14 million for the Native American Caregiver Support Services. And additionally, the budget also invests $14 million within the Office of Strategy to launch a new tribal health quality initiative to improve health outcomes for American Indian and Alaska Native people. Before I close, I want to quickly highlight the work HHS is doing to address facilities and infrastructure needs in Indian country. And as Darcy noted, earlier this year, Secretary Kennedy announced a commitment to focus departmental resources on addressing the backlog of IHS facility constructions. He set the ambitious target of dedicating $1 billion over multiple years to support projects on the backlog priority list. As a first step, HHS recently notified Congress of our intent to utilize $50 million in non-recurring expense funds resources toward IHS facilities backlog in fiscal year 2026. We continue to maximize available funding to address facility needs and will do so in the future fiscal years. Now, looking forward to the 28 budget formulation, HHS continues to take your recommendations seriously and hope you continue to see that reflected in our annual budget priorities and requests. We will soon begin the work on the developing of the fiscal year 2028 budget request, and that work will be informed by the recommendations you all share today, as well as your written testimony. So just to conclude my updates, and I know I went through them rather quickly, but I would like to thank you all for the opportunity to present them here, and I'm looking forward to working with you all and spending the remaining time here to hear from you about your priorities and recommendations for the fiscal year 2028 budget. With that, thank you very much.
Executive Director Yazzie.
Good morning. Thank you so much for your report to tribal nations here, and I just want to thank you on behalf of the work group. Thanks Secretary Kennedy and HHS's leadership for your continued support for tribal nations and our healthcare needs. We recognize and appreciate the Secretary's genuine commitment to engaging tribal leaders. However, we are still concerned on the focus outline that you presented today. Were not really initiated by tribal direction and were created without meaningful, proactive tribal consultation. There has been much discussion today with regards to the focus outline on the tribal on the budget, and we encourage leadership and staff to carefully review and look at the work group's recommendations that we have all worked tirelessly towards and remain actively and engaged with our tribal leaders and our health experts. Meaningful considerations of our fiscal year 2028 requests is critical to fulfilling the federal trust and responsibility of all nations, tribes, and pueblos. Thank you.
Chief Allen, or Chairman Allen.
Thanks, Mr. Chairman. I appreciate the summary of the points that you're making, and I definitely appreciate that that the administration is supporting the advanced funding for Indian country. Healthcare doesn't wait for Congress to get their act together. So I think that's true throughout America, quite frankly. You know, when I look at the overall HHS budget, $2 trillion plus, you know, when you deal with Medicare, Medicaid, and all the discretionary programs, I didn't quite get the number you said about the discretionary. It was about, I think you said 136 billion, something like that, 126 billion. So it's a small piece, but the Medicaid, Medicare is a part of how we provide services to our people. Third-party revenue is critical. So when I look at the IHS budget alone, which is initially targeted at addressing the health care for Indian country, it wasn't covering the base. You'll see in our recommendations that the true need today is not 8 or 9 billion. It's like 75, 76, 77 billion. And we come up with that number using the metrics that are commonly used with regard to delivering quality health care, from initial primary care or dental or other programs that are out there. When we look at the budget for HHS, we without a doubt, we're looking more holistically. We certainly understand MAHA and the initiatives of the Secretary, but the question of the day, when you deal with the complexity of 575 Indian nations, from Alaska to Florida and California to Maine, we're a complex set of communities, and one size doesn't fit all. We're not all using exactly the same system. So we appreciate that the budget is complicated, it's layered. So there's the programs that are out there that provide the essential care for our citizens, but there are complications out there that are needed. So, you know, just the brick and mortar operations for clinics and hospitals and ambulatory programs, et cetera, the infrastructure that's needed, including sanitation for our communities, is critical for us to be successful. But O&M, the operation, in my small community, I have a primary clinic, dental clinic, but I had to go out of my way to provide for the resources to build a facility for behavioral, not behavioral, but for substance and opiate abuse, fentanyl, et cetera, and an outpatient program. You know, that cost my small tribe, $15 million just to do that. No help from the federal government. And I can tell you the 16 layers of certification that I need to get, system was not very friendly, quite frankly, in order to make that happen, to serve people who are in need. I'm right in the middle right now of building without your help, a $32 million inpatient program for behavior and mental health. So when I look at the budget, and I see, mental health being reduced, but then I also see that this new block grant. We got to know how this is going to work. How are we going to access that? Behavior and mental health issues are challenging in all of our communities, and we have to serve them. Guarantee you, most of our operations don't have that kind of facility. And to hire a psychiatrist to come to work, to be able to have the quality of care that is essential to make it successful and effective, it's costing me $350,000. Most of us are in rural areas. We have to compete with urban communities for these high-profile, highly successful, very effective professionals. I got to lure them to my rural community in order to serve our community needs. That's not an easy lift, quite frankly. So the system has to be very supportive of us to be able to be effective so that our clinics and hospitals and our programs can be effective and successful. But having said that, I'm just looking right at the programs dealing with the issues that we face every day. The Secretary is really about preventive initiatives. Eat healthy. Okay, we're all about that. We'll get into that conversation later, but we're all about that. We agree. But the preventive health care activities, so like ACF programs, we get a little worried when you start moving programs into other categories and other areas, and are we losing traction? The aging program is an issue for us. Is it a technique to move and then you reduce commitment to that objective? America is aging, and so are we. So, the issue to us is that we need to make sure that the treaty trust government-to-government obligation from the federal government to the tribes is going to be effective. They got to be meaningful, and they have to serve us large and small, large land-based tribes, small land-based tribes, small tribes in numbers, large tribes in numbers. So it is a complexer world. But nobody falls off the bench. And so that is critically important to us. So we're in the second year of this administration, and we're planning for 2028. But meanwhile, it's how we're going to get there. And so the budget, quite frankly, is critical. We're talking about direct health care stuff, Head Start programs, LIHEAP programs. They make a difference in our communities. So the Title VI programs, you know, for elders, it makes a difference, quite frankly. So when we look at it, I would like to get a copy of your talking points, but it's helpful. And just yesterday I got the full budget, and I didn't have time to wade my way through it. You know, the parts that I got was IHS and BIA and HUD. So then when I dip down into HHS and all the agencies, HRSA, you know, CDC, how are all they going to contribute to our program needs? I can tell you with public health care, the pandemic happened. It happened. And quite frankly, most of us didn't have public health care officials. Most of us had to scramble to get public health care guidance to protect our people, and we lost a lot of folks, unfortunately. So we need to be thinking about that as we move forward, and the budget and the access to the budget, how the budget treats our respective communities is critical for our success. We want to be more self-governing and self-reliant. We can take federal programs and we can do them better than you. No offense, but we can do them better than you, because the system has a hard way to understand the complexity of Indian country. So, you know, Pueblo country is different than Jamestown country, and so forth. So we need to make sure that the system is flexible and respective of how you can help us make a difference. 105L and CSE is a part of it. CSE is simply the functions you do to provide services to us. That's all it is. And so it has to be a part of it. So I can tell you that advanced funding helps. Mandatory funding for health care and you know, the 105L or the CSE for Indian country should be essential. It should be the future. Now, I get it. We're 39 trillion in debt. You don't want to go deeper, right? Nobody wants to go there. But the resources dedicated for Indian country is but a drop in that bucket, in all fairness. So anyhow, that's the pitch that I want to make as you move forward. You know, as we're going to be moving into 27 shortly. We're going to move into 28 and beyond. And that's what's on our minds as we're continuing to get stronger, but we have a long ways to go. I'm sorry, Mr. Chairman, I was so wordy.
Thank you, Ron. Chief Harris.
Good morning, Mr. Chair. My name is Chief Harris, and I am the Chief of the Catawba Indian Nation. I'm also the USIT representative here for the Nashville area. And so to piggyback on what the chairman is saying, and I understand, accept, and appreciate your open remarks and some of the numbers that you threw out there, but historically, as you are well aware, IHS is very underfunded. Indian healthcare is underfunded. I would even say less than 50% of what we really need. And as the chairman stated, you know, we need probably $75 billion just to get up to speed and current. And let me just put something in perspective here before I give you some opening remarks, and I'll have like 3 questions at the end of my opening remarks. Every member, every leader around this table, respectfully back home, our communities are underfunded, right? When the current burn rate of the Iran war is about $2 million a day, $2 billion a day, which is about $14 billion a week, which is about $30 to $50 billion a month, and yet we are underfunded. I know there's nothing you can do about that, but we have a work group here that we put together. I don't know, there's probably about 12 different areas, as you can see here, maybe 25, 30 different people. Got our budget over here, and we respectfully ask you, sir, not to touch this budget, to keep it in place as we've recommended it. Okay? So with that being said, I want to thank you from the Catawba Indian Nation and member of the STAC community for being here today and your continued support, along with Secretary Kennedy, because I think that he gets it. He's been I feel like he's been very helpful. But I just wanted to put that in perspective and piggyback off what the chairman here said. And so with that being said, I'm going to go into some talking points that we've generated here, okay? And so, as I just stated, we put together the National Tribal Budget Formulation Work Group, and they met February the 10th through the 11th of 2026 to discuss and develop recommendations for the IHS fiscal year 2028 budget request to Congress. Okay? The work group recommends $76 billion to fully fund Indian Health Service for fiscal year 2028. The government has trust and treaty responsibility to Native American tribes. It's enumerated in the Constitution. It's backed up by those trust and treaty responsibility. I don't think the United States has trust and treaty responsibility with Iran. And we're spending billions over there daily. So with that being said, this total includes $18.1 billion for hospitals and health clinics, $13.1 billion for purchase referred care, $5.6 billion for mental health, $3.8 billion for the Indian Healthcare Improvement Fund, $4.6 billion for alcohol and substance abuse, $1.6 billion for the Sanitation Facilities Construction Program. Actually, that's kind of low. It should be more than that, but $1.6 billion for the Sanitation Facilities Construction Program. The work group requests mandatory appropriations for IHS and to maintain advance appropriations for IHS until mandatory funding, which we've constantly and consistently asked for here on the STAC committee. Mandatory funding is fully codified. Full mandatory funding to IHS is essential, sir, to upholding the federal government's trust and treaty obligations to tribal nations, as I have identified earlier. The IHS is chronically underfunded, as we already know, and is estimated to be currently funded at only 11% of the true level needed, which is roughly about I don't know, somebody help me out here, about $4,000 per citizen. I mean, VA spends $10,000 on veterans. I'm one of them. I get service from there. But $4,000 per tribal citizens is just galactically stupid, if you ask me, sir. The IHS is chronically underfunded. While tribal health care systems continue to stretch their limited federal dollars, any decrease in funding will have devastating consequences on health and well-being of American Indian and Alaska Native people. Cuts to the IH budget would not produce any meaningful savings toward the national debt, not when you're spending that kind of money overseas in a war that is suspect, toward the national debt, but would instead create life or death consequences in the Indian country, as the chairman here stated earlier. So with that being said, that's kind of some opening comments there, but I have a few questions that I like to ask. So how does, what safeguards are you, sir, currently putting in place to ensure that tribal health funding is protected from reallocation or cuts mid-cycle? So that's my first question. So what safeguards are being put in place currently, right here, right now, today, to ensure tribal health funding is protected from reallocation or cuts mid-cycle? Second question. At the end of this fiscal year 2028, what specific, and I asked this question last year, I never really got an answer. So once everything, the I's are dotted, T's are crossed, at the budget, what specific measurable improvements in tribal health will you stand behind, and what accountability mechanisms are in place if those outcomes are not met? Third, what authority can you, could you, should you, this year or next or the following year, are you shifting to tribes so we design and control the program serving our people? And that's my third question.
Chairman LaPlante?
Vice Chair.
Vice Chair.
Thank you. Yeah. Don't tell Austin that. So, I don't want to repeat everything that's already been said, so I'll just say this. Like, if we can't come to an agreement, like, we have to just start pushing. We have treaties with the U.S. government, and if we can't come to an agreement that we're going to take care of our people, according to my treaty, the Treaty of Washington, healthcare and welfare in perpetuity, as well as education, but that's another battle within the state. It should be a battle with the federal government. But at this point, I think we just need to go into discussions about having land back or a share of the taxation of the land that you guys are able to take, because that territory was ceded through treaties. So I'm going to stand firm with that, because, we had an agreement and it's not being met with the federal government. And that'll get rid of the budget discussion, because then we won't have to be concerned about it. We'll just take care of ourselves from there. That is the best way for us to take care of ourselves, is just to manage the land that we used to manage. Going back to one of the points about third-party revenue and CMS funding, it is very important. As long as IHS or any of these budgets are not fully funded to help treat our people, we do need access to third-party revenue. And we also do a very good job of it. However, there are barriers set in place by each state, and that shouldn't happen for Indian tribes. We should not have to work with MCOs. We should not have to work through state plan amendments. If we have access to a federal program for CMS, we should have access to that federal program without having to beg or initiate discussions with the states who have no treaty responsibility to us. It is a federal program, and we should have direct access to it without having individual state plan amendments. So I would propose, and I know this is beyond you for the budgeting, but I would propose that we move forward with some kind of federal ratio with tribes, where if something is allowable, it is automatically mandated to the states to be allowable, so no tribes have to argue about CMS, access to CMS services anymore. You know, we're seeing awesome programs, pilot programs of traditional medicine being reimbursed in the Southwest. I think that's fantastic. I want that. Our tribe is one of the leaders in traditional medicine. We integrated it into our EHR and our health system so that it does not mix with Western medication, and helps us stay healthier and manage medications for our patients. So that's one of the huge things, because unless IHS gets fully funded, third-party revenue is going to be a main key driver for this. 105L leasing, a very important example. I am the furthest representative of my 7-county service area in the Upper Peninsula of Michigan. We never had a health center before. Our closest health center was an hour, but we have really harsh winters. And this winter, the highway between health clinics was shut down quite a bit because we had such a harsh winter. Our health center in Marquette, where I live, went live this year, and no longer are those patients getting inaccessible care because they can have care at home. We're moving that into a 105L lease program, but again, there's an approval process and it's not mandatory. So without the mandatory, we wouldn't have had a health center, a new health center, for 460 years. Like, we have to build our own in order to do this. And that's, again, part of IHS's responsibility. It should not fall on us, but we took it upon ourselves through our third-party revenue. Access to care is also a direct indicator of quality of life. And quality of life is really important, especially when we're dealing with historic trauma, generational trauma, and substance use and mental health issues. The healthier we can create a person as their body, their spirit, and their mind go with them usually. And when people do not have access to care, when they do not have access to dental, it exasperates the other issues. So again, this is why it is so important to make sure and to ensure that IHS is always fully funded. So like we're basically begging for scraps. We're not even getting 15% of what's being asked for. So saying an 11% increase on what's already being given isn't a huge increase for us when we're talking about barriers. Our tribes have to use our economic development capacity as well as our third-party revenue generation in order to manage our citizens. Our tribe has 53,000 people scattered throughout the country, the Sault Ste. Marie tribe. And we have roughly 13,000 user patient population of our own people. So we're managing the care of those people, and those people are also rural health citizens or rural citizens of the United States of America. They're dually enrolled into the United States and the Sioux tribe. So we are helping manage their care, which actually takes a cost burden off not only the state of Michigan, but off the U.S. government as well. So the better we can manage that care through these resources, because funding is health care, the healthier there will be, the less burden they will be on the entire system. And with that, I'll just yield.
Executive Director Mettens.
One of my concerns with the budget coming in is that you're not shifting money away from current projects to fund something. For instance, like with your EHR, I know you've always been putting a lot of money into the EHR, but at what cost? Because the impression that it's my impression that you've moved money from sanitation facilities to do that to cover it, so you're not really covering you're robbing Peter to pay Paul, and neither one can afford it. That's the impression that I have and a concern.
Councilmember Cutts.
Yeah, the issue of the EHR has been, I think, of quite concern for us for a number of years, and you've inherited it. The funding to properly implement has never been there. It comes along in fits and spurts, and what's going on in the meantime, the rest of us out there have to buy our own EHR. So if I go to buy an EHR for one of my clinics, it's $1 million out the gate to buy that EHR. And many of us are doing that. We're having to do it because we can't wait. We can't wait. You have new tribes here that, what, are they going to implement RPMS? No, they can't implement RPMS. They have to have something. And so, so this is something that we cannot afford to have money removed from the IHS budget to implement such a critical piece of the infrastructure. And so we're hoping that you can kind of take a look and move that forward in some way faster. You know, right now, it's going to be probably about 2 to 3 years before it matriculates through the IHS system that the government runs before it then goes to tribes. We can't wait. So thank you.
Thank you. Assistant Secretary Sherrill, before we go in, I just want to reinforce some of the points that were made here today. You know, the IHS 2027 budget recommends a large increase for EHR funding. Does the IHS use tribal recommendations when calculating its proposed budget? If so, how did IHS make the determination for the EHR increase while only 3 IHS areas recommended increases to the EHR funding? Many tribes have already invested in the EHR upgrades because they could not wait for IHS to meet our EHR needs. We recommend HHS requires IHS to do this so that we can support EHR modernization. Tribes may be more willing to support this once they understand how funding will impact them. Right now, tribes do not receive any funding for the EHR. I'll stop there and I'll let you respond, Assistant Secretary Sherrill. Thank you.
Well, thank you, and thank you all for this, and again, for initiating the dialogue. In my opening remarks and here, and this is, you know, my first time here, but let me give you a little bit of background about myself. I came into this position, I'm an antitrust lawyer. I've been at the FTC for many years, and as a competition lawyer, when I sat down with the secretary when I was in the process of interviewing, I said that there's lots of places in this country that are suffering due to lack of competition. And by that, meaning that I looked at things a lot through state interventions, state laws, state regulations that prevent health care from being delivered to, in where I was focused on at the time, was rural health areas. And so one of the lessons I learned over my career at the FTC is that good policy comes from good questions. And when we look at markets and when we look at, particularly in healthcare markets, why things aren't getting where they need to be and why decisions are being made is important. One of the things that attracted me to working with Secretary Kennedy is a few things. One, his commitment to radical transparency. People should know how their money is being spent and why decisions are being made. And so you're asking very good questions on that. Second thing is, and I think the chairman over here was saying, some of those innovations in healthcare delivery are actually are occurring in Indian country. When I was early in my career at the FTC, we were looking at dental health, and the dental community was very resistant to delivery of health care through dental hygienists and other folks who don't have maybe the full licensing of a full dentist. And it was in Alaska that they were adopting a different program out of complete necessity because there was a dearth of care there in a dental therapy model that then Minnesota was trying to develop. The institutions, some of these medical institutions are difficult to take on as far as delivery of access to care. So, but kind of framing all of your issues in there, I'm approaching this process differently than I think any other ASFR has. I'm the first Republican ASFR since the Bush administration, so I'm bringing that maybe a different perspective. But also, I'm not looking at the 2028 budget process as business as usual, and as the agency is about to learn, I'm going to be asking different questions because I believe we have to, A, put less of a burden on our economy as far as healthcare, but also deliver to the people who need it most, which is your communities. So things like the electronic healthcare records. Electronic healthcare records are expensive, but also huge efficiency drivers for better healthcare delivery because your care can become more portable. Finding better ways to serve that are going to be a priority for me to ask better questions as to why. You're asking an important question on trade-offs, on sanitation versus EHR. My mother was a public health nurse, and I grew up in upstate New York, in Cooperstown, New York, and she was a public health nurse who became an epidemiologist and then went on to work at the CDC. The basics of good health care start with sanitation, with cleaning, being clean and avoiding the spread of disease that way. So I'm going to ask those questions. Why are those being compromised? If they are being compromised, why and where and what decisions are being made? What is the role of the state where you all reside in there as well? Those are the types of questions. I don't have answers for you today on those areas, but those are, I give you my commitment that when we're going through the IHS budget and those areas, I'll be asking those questions. Why are those trade-offs being made, and are there better ways to address them?
You need to know that, right straight in front of you. Oh. You need to know that state to state, there's 35 states that have tribes in it.
Yeah.
And our relationship with those states vary. Right. Some are friendly, some are not. And so they do have a role because we are citizens of those states. But it's a mixed bag when it comes to health care.
Sure, and that we see that in how we look at monies we send to the states, and for block grants and other programs, that how they are accountable for spending federal dollars varies from state to state very broadly, and we're taking in my office taking a renewed look at that and how we are conducting our audits of them and how they're being accountable because. When I started looking at this, but I've only been on the job for about 6 months, but when I looked at these areas, I was aghast at the breadth of responsibility state to state they take as far as spending money, and we're going to focus it on that. That's not necessarily for the conversation here, but that kind of, I'm trying to educate you a little bit about my perspective that I'm trying to ask better questions to see where the leakage is, because if we have we look at the HHS budget of, say, $2.1 trillion, depending on how you count the spending, which is more spending than all but 8 or 9 countries on the planet. And what that accounts for 340-ish million Americans is about $6,000 per person is what it costs before you're spending on your food, on your health care, on your housing, on your clothing, on your basic necessities. So we need to be delivering better quality if that's how much we're spending. And so that's, again, I'm trying to bring accountability and ask those better questions in the process. So you asked me, I think, what safeguards we're going to put in place on was it the cuts? I can't even read my own handwriting. But the safeguards, I guess, on the budget priorities that you have, and I guess preventing cuts in mid-cycle cuts, that's what it was, that I would be shocked if those were to happen unless there was like a cutoff in government funding. But again, I think we've been trying to secure funding to kind of insulate IHS from those risks. But we'll look into those. As far as The authority, was it the authority to design your own programs that you're asking about? I think you were asking similarly. Again, my experience is that innovation in healthcare is an essentially local delivery program. And one thing I bristle at is a one solution fits all type of model. So again, the dialogue that we have, we're starting the process, and for me, I'm really starting the process of listening as to how those differences are there and how we can be better stewards of that. I'm all ears on that, because from my own experience as a healthcare antitrust lawyer, I know that all those solutions at local are good to have. More innovation is better than less. And when you can have information sharing and new ideas across places, we can all kind of better deliver on that MAHA initiative, which again is why I signed up for the position, because I thought I could bring that kind of value into this role. And I really, really appreciate where Secretary Kennedy is going. Number one, in making America healthy again. I know his commitment to Indian country and making your lives better and richer. So, and that's all to say, I really encourage you to lean in with my team that are here throughout this process, the program, and ask those questions. Demand of us the accountability that you're looking for.
I have
Victor, if you don't mind.
Sorry.
One thing that's not said, this is about tribes.
Right.
But there are just a slew of urban Indian health centers.
Yeah.
And, Victor Murillo is, our Walter Murillo is behind me someplace, and he's the head of the Urban Indian Association. Half of Indian country is in cities. They're all over the place. Baltimore, Seattle, Los Angeles, New York. And so we need them not to fall off the bench. The system has to be sensitive. Those are Indians, and they have the same rights. And those programs need to be helped as well.
Right. I would encourage, and I was saying to others, part of what I would like to do is be out there and visit and see. And, for me, I'm a in-person learner. So I'm going to be asking for opportunities to make those visits and when I can travel around to do those. Because I think understanding that and being able to, in my position, to articulate that is going to be a key component.
And I'd like to make one more point with that. Is using the state of Pennsylvania, where there are no federally recognized tribes. 21% of the Pamunkey Indian tribe, their tribal citizens, live in Philadelphia and around. Mm-hmm. We can't give them care because our PRCDA doesn't go that far. And without an urban Indian health clinic there, it's very limited in terms of access. That's what we're talking about. There's no continuity of care for people who don't necessarily live in our areas either. So.
Vice Chairman, please.
Thank you. Just a couple of comments. Tasha Musso, Vice President of the Wichita and Affiliated Tribes out of Oklahoma. I also sit on the National Chat Board. And so, you spoke of getting care to the people who need it most, who, you've said are our people. Appreciate that acknowledgement, but I think the other piece to that is getting it to the people who need it most, how we need it. I think a lot of my colleagues are discussing that in a variety of ways as far as the differences and nuances and diversity of Indian country in each individual nation and area. But the other thing that I will say is the program that you were alluding to is the CHAP program, the Community Health Aid program that started with our Alaska Native relatives, and it is moving into the lower 48 through the IHS. It is slow going, but it's definitely something that we need to continue to look at funding. It's a tribally led initiative because they are mental health aids, medical health aids, behavioral health aids, and dental health aids that will be in the community. I know Northwest Portland has established their area certification board. The Oklahoma area is in the process of doing that. But as with everything else we've discussed, it's underfunded, but those are creating positions and folks and vocations that are going to fill those gaps in our healthcare ecosystems in our tribal nations and tribal communities. So I'd highly encourage you to, since it's something that you saw great value in as it was trying to come into Minnesota, look at what funding for that could be and how that not only supports our healthcare, but also the workforce development priorities of this administration and in creating those pathways for our people. And then, as Chairman Allen said, we won't have to entice people to come to our areas because they already live and work and play in our areas. The other piece of that, and doing it how we need it done, goes to traditional healing and creating pathways that we're able to bill for those services, and also funding to provide those services to our people. What we know is that those things have served us well since time immemorial. There are many instances where you can see traditional healing has cured cancer and things like that, whether it's through traditional medicines or traditional healing ceremonies. And, I think that's one way in which, from a Western sense, we say innovation. But innovation for us is reclaiming the systems and the ways of healing and knowing and being that have been successful for our people. And so creating resource pathways so that we can make that reclamation and offer that as an additional avenue to healing and wellness, whether that is through addiction services or those more chronic diseases. I think those are super important. There are a couple of pilots in traditional healing, but I think it could be greatly expanded, particularly in areas that have those traditional resources available to them. And then finally, as we think about, I appreciate the learning approach to coming into your position and thinking about budgets in a very different way and asking questions of your staff. I would encourage you, one of the questions to ask of your staff is, what questions are they asking us? And not only, it can't stop with the questions. We sit in sessions like this quite often, and we ask questions, we give exchanges, but we see no outcomes. So what do those timelines look like? It's one thing to hear us, it's another thing to listen to us. So what are the outcomes that we see from these conversations that are not merely sharing time and space, but what are these outcomes for our people? Thank you.
Assistant Secretary Shrillo, I have 3 in the queue. We're going to be wrapping it up after the third one, and you'll have the last chance to respond, okay? With that, we have Thompson. Vice President Thompson.
No, it was.
Oh, okay. Sorry, Councilmember Thompson.
Stephanie Thompson, Lac du Flambeau, Ojibwe Nation. So I was really excited to hear about the Make America Healthy Again initiative, especially when we talk about real food. As an Ojibwe, I know about real food. I have canned with my great-grandmother. I have berry picked in the same berry patches that her great-grandmother brought her to. I have speared with my uncles. I have processed those fish. I have fed my family. I have gathered manoomin. I know about real food. I also come from the Dairyland state. We know about our health, the way to take care of food in a way that feeds the masses. With our farmers and our perspective there. So it's difficult for me when we're speaking about these things to kind of dichotomize things into how the budget goes, because there's a foundation that comes with real food, and that's clean water. That's holistic thinking that goes beyond just the human species, that's taking care of all of our relatives, that's taking care of all of the land. And so I see, and I feel confusion by the cutting of these funding and these protections for clean and safe water that impact all of these other areas of the budget. We have 48% of our land base is wet, waters, rivers, streams, wetlands, those types of things. And yet we face significant issues with sanitation. In this last couple of years, we've had outside entities coming to Lac du Flambeau and dumping waste onto our reservation into the heart of an area that has been historically prime hunting land that is no longer usable because of PFAS, because of contamination, and the fact that my children are going to be the first generation of my family to not be able to hunt in that space breaks my heart. So I would urge that you increase funding and really look at how sanitation is handled in Indian country. The hunting and gathering is more than just sustenance to my tribe. It's a way of life. It's how we connect to one another. It's how we stay healthy. And that's mentally and physically staying healthy as well. When I heard on your list of priorities that, addiction is one of those and behavioral health are one of those, I'm an EMT. I have been in a number of situations where I've had to save lives because of mental health or because of substance use issues. And to see this budget and the proposed funding cuts there not only hurt Indian country, but hurt the rest of my rural communities and farther out from there. I'm very happy to say that the first time that I ever had to Narcan and revive somebody, they are now years into their sobriety and celebrating a brand new addition to their family. And that is a great honor to be able to witness that. So when I see programs like this being cut, it deeply impacts. I can't help but think about all of the outside communities and how I watch, because all of our EMS, we connect with each other, we talk with each other, and I see 100 miles away overdoses are beginning to happen, 50 miles away overdoses are happening, now it's in my yard. And I watch that happen over the course of like 72 hours time sometimes. So when you look at cutting those things, I would urge you to consider the holistic impact that those things have. And finally, I would like to really raise up the LIHEAP program, the low-income housing, or the energy assistance program. I utilize that every year. I'm a single mom of 6 kids. I worked 4 jobs last year, and I still qualified for that program. That enabled me to be able to do the things that I do and to work on the things that I do and to give to my community in the way that I do. And so I would urge you to consider funding that program because no one in America should ever worry about keeping lights on or keeping heat going in the home. While you're considering how you change up budgets, I would request that you consider how you do pass-through funding from states through the tribes. I know that a number of the substance abuse programs do pass-through funding, and I would urge you to really consider how the states interact with each tribe. As we know, every tribe and every state have unique circumstances, and some of the states don't necessarily have meaningful consultation with their tribal people. And I would urge that you take that into consideration when you think about how those funding sources come down and how that's going to directly impact Indian country. Our smaller land-based tribes need to be considered in these budgets. And with that, I thank you.
Thank you. Before we continue, give me 1 second, please. We're a little bit over schedule right now. So we can go ahead and follow the next 2 speakers, get a response. I'm going to ask the next 2 speakers to keep it a little bit short, and then we'll ask the next group to extend out a little bit, okay? So with that, Chairman Linke, please.
I got 2 mics here. What's that telling me? My name is Peter Lenkeek. I serve as chairman of the Crow Creek Sioux Tribe. As a direct service tribe, our citizens depend on federal health and human services systems, and we see clearly how the funding decisions impact our communities. From the perspective of the Crow Creek Sioux Tribe, these priorities reflect what is necessary to ensure our people have consistent access to care and basic services. As a direct service tribe, we support the call for mandatory full funding of the Indian Health Service. We strongly support expanding advanced appropriations. Delays and uncertainty in federal funding directly disrupt services in our community. Advanced appropriations help ensure continuity of care and protect against government shutdowns. We emphasize the need to fully fund contract support costs and Section 105 lease obligations. These legal requirements tied to the tribal self-determination, and tribes should not be placed in a position of subsidizing federal programs. We urge the protection and restoration of funding for the Special Diabetes Program for Indians at no less than $200 million annually. Diabetes continues to impact our community at high rates, and SDPI provides proven community-based solutions that improve outcomes. The proposed cuts to sanitation facilities construction are deeply concerning. Access to safe water and wastewater systems is a basic public health need. Reductions in this area deeply impact the health and safety of my people. We support increased funding for PRC, Purchase Referred Care. In a direct service setting, PRC is often the only pathway my tribal members have to access specialty and emergency care. Current funding levels do not meet the need. We support continued investment into the EHR modernization, but emphasize that tribal systems must be supported and respectful tribal data sovereignty. We strongly advocate for the continuation of tribal behavioral health programs. These programs are critical in addressing suicide, substance use, and trauma in our communities. We urge HHS to maintain public health and prevention programs, including those with the CDC that support tribal communities' prevention and essential to reducing long-term health. Finally, we emphasize the importance of protecting the broader HHS programs such as LEAP and workforce development, which are crucial and important to the future of our nations. LEAP saves lives, which directly impact health outcomes in our community. The Crow Creek Sioux Tribe strongly urges HHS to maintain and strengthen tribal behavioral health programs within SAMHSA. The tribe also advocates for a continuation of CDC public health and prevention programs, including Healthy Tribes and National Diabetes Prevention Program. These programs are essential in addressing chronic disease disparities in tribal communities like Crow Creek, where access to preventive care is limited and rates of diabetes and related conditions remain disproportionately high. Prevention investments reduce long-term cost and improve overall community health. The Crow Creek Sioux Tribe strongly opposes the proposed elimination of the Low-Income Home Energy Assistance Program, or LEAP. As we said, it saves lives in Indian country. The tribe urges HHS to protect and expand workforce development programs. And these programs must be understood as interconnected components of a direct service system. The Crow Creek Sioux Tribe federal services alone do not meet the full scope of the community needs. The tribe emphasizes that these programs are not optional. They are necessary to uphold the federal trust responsibility. And I want to speak to the young woman who talked about pass-through the state. My treaty predates statehood of South Dakota, but yet I have to go to them to get services for my people. I think in the future you really need to take a hard look at the relationships between the tribes and the states before you make decisions like this. A lot of times them relationships are not strong, not solid, and cannot hold up to anything. The Crow Creek Sioux Tribe urges HHS to prioritize stability, continuity, and partnerships, ensuring that any structural changes strengthen, not weaken, the systems of care that tribal communities rely upon every day. Thank you.
Thank you. Mr. Bunch.
Thank you, Mr. Chair. Thank you, Assistant Secretary, for your time today, and thank you, Mark Cruz, for your time today. And also want to thank Secretary Kennedy for his commitment to Indian country. I'll make it quick, Chairman. Cherokee Nation, our reservation, 7,000 square miles in northeast Oklahoma. We've been there for less than 200 years since we were forcibly removed by the federal government to Indian territory. It is the responsibility of the federal government to provide for the health, education, and general welfare of Native peoples because of what's happened to us. You brought up many things, and I feel compelled to address them. First of all, thank you for the advanced appropriations for the IHS dollars. But as you mentioned, there's other programs within health services and Head Start programs, for an example, that could benefit from advanced appropriations. During the recent government shutdown, the Cherokee Nation under the Hoskin-Warner administration was fortunate because we're in a sound financial position to be able to continue our Head Start services for the longest shutdown in government history, meaning that we were able to still provide those services for nearly 1,000 students and families. So I'd like to, for you to consider that in future budgets. Also, I want to mention that the Cherokee Nation, we operate all of our own healthcare services, 1 hospital and 10 clinics across our reservation. We do quite extraordinary work, and don't take my word for granted, and like to invite anyone from the department to come and visit the Cherokee Nation to see how we operate, especially Secretary Kennedy. We serve over 3 million patient visits a year at the Cherokee Nation. Healthcare, Head Start, and some of the programs under HHS are more than half of what we do at the Cherokee Nation. We have over 4,000 employees who work in those areas, so it's more than half of what we do. So we're thankful for that. But IHS has been brought up as only 11% funded by many calculations. That's woefully underfunded. States have been brought up. The state of Oklahoma doesn't work very well with the tribal nations, the 30 or so tribal nations in the state of Oklahoma. We have to find a mechanism for receiving Medicare dollars directly for tribes who are interested, instead of those being sent through the states like we do in Oklahoma through the Oklahoma Health Care Authority. Recently, the state of Oklahoma, some of the legislators there, they're attempting to really cut back or eliminate Medicaid expansion. That will directly impact all of our tribal citizens. The Cherokee Nation, again, we're one of the larger tribes in the country, have just around 478,000 tribal citizens, not to mention the other federally recognized citizens that we serve in our health services system. It was mentioned by the Vice Chairman that we don't collect taxes. The states collects taxes. So we have to find a better way to receive this funding. That would be much appreciated. I'll make it quick. Just one last question, Chairman. It was brought up about questions. What data can we provide the HHS from the Cherokee Nation, whether it's through our health systems, Head Start, Human Services? What data can we provide HHS to better drive the budgeting process? Oh, lastly, I wanted to mention also the LIHEAP funding. We use ours. We've served over 2,000 elders and those with disabilities to provide energy assistance. And again, that's up for elimination, and it should not be. These are services that are desperately needed by many people throughout Indian country. Thank you for your time, Mr. Chair.
Thank you. A couple minutes to respond, please.
Again, thank you, everyone, for the comments here, because again, this is a great forum out of which a lot of good progress hopefully will spawn. And Mark handed me, reminded me, because as you know, this is my first one, but I know from previous ones, the advanced appropriations was something I know that was a priority, and that came out of discussions here. The fully funding the 105Ls and the CSC, again, is a result of some of the discussions here. Increasing the budget to $9.1 billion for IHS as a result of the discussions here. And the $1 billion that we pulled from the NEF to start the construction on the long overdue 1993 priorities list is a product of the conversations here. So that's not to say that the progress is done, but it is to say that the dialogue is somewhat working. To your point on the important relationship between nature and the lifestyle of hunting and gathering and those things, and the rivers. And you know, I'll just remind you that everyone knows Secretary Kennedy learned a lot about that. He cleaned up. I was a beneficiary in upstate New York when he cleaned up the Hudson River and other rivers here, because he understood that. And he learned that a lot from his father and his family, but also the relationship he had with the communities here. So I know that those are beliefs that he holds dear, and we all do. Another thing I will tell you, my background, my ancestors are from Italy, and I'm a Catholic, and St. Francis of Assisi has a prayer that it begins with, God, make me an instrument of your peace, and then it has a litany of behaviors that you want to do. But in there is, let me seek not so much to be understood, but to understand. And when you were saying what you were about understanding the why of why the care that you need in your communities is necessary, I don't understand yet, but I'd like to understand. And not tell you how to do things, but understand why it is important for your communities to get the help you need, and the ability to deliver the care in the way that you need to deliver it is an important piece of the dialogue. I know Mark here huge advocate here inside the department and huge source of information for me as we learn. But taking these from these questions that you've asked and they're convicting questions is really quite helpful because it will help inform the process. Again, this is just the beginning for this year's process. I've got my team is here throughout. They'll be listening. And I encourage you all to keep the dialogue coming through Mark, coming through Darcy, coming through the agency, and through us. And I hope to be able to be out. I can't probably go everywhere, but I've asked to go out there. Next week I'm going to Oklahoma City for a conference on the Buy Indian program. But I'd like to be able to visit and dialogue because this is how you learn and this is how we can be best stewards of the monies we have and make the best decisions that we can through those dialogues. I know I didn't answer all of the questions, but I've taken down best I could. And if there's further follow-up, I certainly invite that. So thank you.
Okay.
And thank you again for the opportunity for this.
We'd like to thank you for your presence here today and for listening and hearing us. The one thing I'd like you to walk away is you're asking questions of your staff or the agency leads. Always ask them, how does this meet the tribe's priorities? And did you consult with them? Those would be a couple very important questions to ask. Thank you. As we're closing this, I want to just thank them one more time, give them a little bit of hand here.
Thank you.
And we'll open our next session. We're running a little bit behind, so I want to apologize to those that are waiting. We have Acting Director Piercy, Chief Medical Officer Christensen, Principal Deputy Director Koval, Assistant Commissioner Metler, and Principal Deputy Lazar. Okay, we'll go ahead and begin this next session. Real foods of Indian country. I'll ask that all comments are kept brief. You can see we have a lot of questions, and this topic brought up a lot of discussion. So I'm hoping that we'll have a lot of good dialogue, okay? With that, we'll go ahead and turn it over to Chief Medical Officer, Indian Health Service, Christine.
Yeah, thank you. It's really a pleasure to be with you for today's session, Real Food in Indian Country. I can't thank you enough for joining us because this is both important and timely. This is designed to hear directly from you how we can strengthen access to nutritious, affordable food and support healthy eating habits to improve outcomes across tribal communities. We know that food is more than nutrition. It's medicine, it's culture, and it's central to the health and well-being of our people. At the Indian Health Service, we're advancing this work through initiatives that support food sovereignty and address root causes of chronic disease. One key example is our Produce Prescription Pilot Program, which we call P4, through our Division of Diabetes Treatment and Prevention. But this goes beyond access. It's built on partnerships with you between healthcare providers, local food systems, and community organizations, allowing each participating site to tailor its program to a community's need. Today, the work that's underway in tribal communities includes Laguna Community Health Center, Muskogee Creek, Pasquiaki, Rocky Boy Health Center, and Sage Memorial Hospital. So our goals are very clear: reduce food insecurity, improve dietary health, increase consumption of nutrition and culturally relevant foods, and ultimately improve our health outcomes. And we're already seeing meaningful progress. So this is exactly why your voice matters today. We are here to listen and to learn what's working, where there are gaps, and how we can better support tribal communities in advancing food sovereignty and improving health outcomes for further generations. Thank you again for being here, and I look forward to hearing what you have to say in meaningful discussion. Thank you.
Executive Director Yazzie. Oh, okay. Sharon?
Thank you. Morning. Sharon Stanfill. I'm the Chief Health Officer of Government Affairs, and want to thank you for being here today. As we speak today of increasing access of nutrition foods as well as affordability, I'd like to just take a brief moment to talk about the SDPI program. And as you all know, nutrition is one of the major components of SDPI. This program is, without a doubt, one of the most effective public health programs in this country, thanks to tribes and the work that they've put into these programs, and no other public health program can match SDPI's record of achievement. We know that over the past 30 years, tribes have helped be able to decrease hypertension for their tribal members, renal failure, hospitalization, heart disease, as well as incident and prevalence of diabetes. So we're proud of the work that we've done in Indian country, and nutrition is, of course, one of the main foundations of the work that we've done. Want to talk a little bit about the appreciation of the flexibility of the program that we've had to date, that tribes are able to pursue their own policies and their own programs under this umbrella of SDPI. We know the savings of Medicare, well over $500 million, probably closer to $1 trillion by now. That's a pretty old data point, but just end-stage renal disease and for Medicare alone. So what we're requesting is that the administration will help us secure and to be able to support us for permanent reauthorization of this program. Only about half of our tribes in this country have SDPI. We need advance appropriation for these funds and for the funds to be taken out of the grant process. We lose staff, as we know, we lose resources. So when it comes to SDPI and nutrition and traditional foods, we really need to make sure our programs can be now put into our compacts and contracts. And we need IHS and the federal government to help us do that. I think that my colleague here from Jamestown has some more information that she wants to share about some of the programs. Yes, please.
I like it.
Thank you. Lonnie Greninger, Vice Chair for the Jamestown Squalum Tribe. I know that CDC isn't a part of this panel today, and I'm disappointed to see that. So if there's someone that can pass on this message, I do see that the Healthy Tribes Office is looking to be eliminated by the President's budget. This happened the last time as well, and there were many of us tribes that came forward last year to advocate in testimony in front of congressional members. And so I want to make this point again, that the Healthy Tribes Office, with there are 3 programs. I'm going to highlight 2 in particular: TIPWIC and GWIC. So TIPWIC is the Tribal Practices for Wellness in Indian Country. GWIC is Good Health and Wellness in Indian Country. And those 2 particular grants have been funding traditional foods programs for tribes for many years. In fact, Jamestown is a recipient of this grant, I think, for the last 4 years. And in one of those, we have a partnership with Northwest Portland Area Indian Health Board. And this has been funding our traditional foods garden, which has been serving our elders and our youth and then our working families. And it's been amazing to reintroduce our families and our children and our elders to the Indian foods. Our elders have memories of being able to have these traditional foods before the commodity foods era came to be. And so I had one elder describe it as feeding her inner Indian. And so being able to reintroduce these nutritious foods back to our elders and then introduce them to our children who have never tried them before until they're in the 4th grade, let's say, as an example. These particular programs are not only increasing our physical health because you're eating nutritious foods, so you can reduce your diabetes, you can reduce all your health disparities. It keeps us as Indian country from being number 1 in all of the health disparities. We hate being number 1. So we also give opportunity for our people to be out there in the gardens. Now you're increasing your physical health in that way. It's increasing your spiritual health because you're getting out into nature. You're putting your hands in the dirt. You're on your hands and knees weeding and harvesting, and it's an amazing experience. We do our singing and drumming out there. We help our folks learn how to eat these foods through cooking them and processing them. So we actually will take produce at the garden, bring a barbecue and a stove out there, and cook these foods, and then we have a soup or a healthy salad right there for our members to be able to eat them directly so they know what they taste like and how to make them taste well. Oh, it's so good, all those wonderful spices and foods mixing together. So I want to advocate that these particular programs in this office, which is now under the Division of Nutrition, Physical Activity, and Obesity under CDC, making sure those programs stay intact and making sure that as HHS as an agency is supporting these programs moving forward, even though they're on the chopping block. Thank you.
Thank you. And before we go into more dialogue, I wanted to give the other panelists if they have anything to say. Koval? Kim?
This is Eric Miller, just from Food and Drug Administration. Just want to say thank you for letting me be here. One thing I do want to stress is that once you've seen one nation, you've seen one nation. And so, we do take the understanding that, we need to know and understand what you guys specifically need and to build on that. And so when it comes to food safety, and we're talking about traditional foods and things like that, again, in the processing of it, we really need to hear from you in our guidances, anything else that we're putting out there. We do have a lot of working groups that we would really encourage you guys to be on. FDA is a very big place. So please, we do have a centralized location, which is the Intergovernmental Affairs Office, and Paul Alice is waving his hand over there, so you can pin him down later, or myself. But really, again, I think the biggest part about this is we need to hear from you. FDA, I think, and the tribal nations don't really speak to each other that much, and we do want to change that quite a bit. So I'm excited to hear from all of you today and continue that after.
Deputy Director Koval.
Good morning. Thank you for the opportunity to be here and your continued partnership. At the Administration for Children and Families, we recognize that access to nutritious, affordable food is foundational to the health, well-being, and economic stability of tribal communities. We understand that food insecurity in Indian country is complex. It reflects affordability challenges, geographic isolation, infrastructure gaps, and the need to preserve and strengthen traditional food systems. Side note, I live in Alaska. I get it. Food is more than sustenance. It is a part of life. Food, culture, and language are deeply interconnected, and traditional knowledge is often passed through native languages. And in many tribal communities, there is long-standing understanding that food is medicine. Bold font, that. Supporting physical health as well as cultural and community well-being. And across ACF programs, we support nutrition and family well-being. Just to jump in with IHS, the budget includes $118 million for service to Native families, including $54 million to support tribal elders through nutrition and caregiver support programs, as an example. Head Start is another key program in delivery of nutritional food programs as well, and building healthy habits rooted in culture and language. They've asked me to cut my comments short, so I'm going to say in close that we recognize tribes are best positioned to determine what works for your communities. We are here to listen and to learn from your guidance. Your input is essential in ensuring our work reflects tribal priorities and leads to meaningful, lasting improvements in the health and well-being of tribal children, families, and communities. And if there are any question and comments, I'll be here all day tomorrow and Thursday as well. Thank you.
Thank you. Principal Deputy Administrator Lazar.
Thank you very much, sir. It's great to be here with all of you again. I was so happy to hear you talk about gardens because ACL, I'm representing the Administration for Community Living. We are soon to be announcing a grant. It's a prize challenge, actually, that will address community care connections, cultivating community connections through gardens. And so there will be grant opportunities or funding opportunities for that very thing. And you described it so well, I can't even say one word better than what you did. So thank you for bringing that up. You will not ever hear me talk about meals programs because it's not a meal that's important. What's important is the nutrition intervention. So ACL is certainly involved in twofold. One is both congregate meal sites, most preferred, because that intervention is one where you're getting the social interaction, you're getting community engagement, you're getting out of your home, you're out with other people, you're talking, you're sharing cultural values and social opportunities. And that's what's very important. As well, there's some exercise involved in getting from one place to the meal. So it's important that we not talk about just food or just meal, but that these are such important interventions. Food is medicine, the meal is medicine. It goes beyond all of that, and we recognize that. And we think that what's very important is that we learn from you what's culturally important so that we can help to share and scale that through our interventions and our support. So what's really important to us is that what you tell us is important is what we share broadly with others. One good idea needs to be spread broadly so that others can pick up on that. But for those who cannot get out of their home, what's important is that there's a social meal intervention, a nutrition intervention that brings the food to the individual, but the intervention is now someone's at your home engaging with you. If the person is really trained appropriately, they're engaging with you. I can tell if this person is doing well and understanding, oriented. How well are they walking in their home? Are they holding on to furniture as they walk around? What's the skin integrity? Is there swelling? Is there bruising? Is there odor? All of these things are part of this nutrition intervention. And so both of these nutrition interventions are important and something that's key to our nutrition program, and we want to make sure we stand that up with all of you. So thank you for allowing me to be here to listen. Thank you.
Thank you. Acting Director Piercy.
Good morning. It's a privilege to be with you all today and to listen and learn from everyone. I'm Commander Katrina Piercy, the Acting Director of the Office of Disease Prevention and Health Promotion, or ODPHP. ODPHP is one of several offices that sits within the OASH umbrella alongside other offices such as the Office of the Surgeon General and the Office of Minority Health. ODPHP's mission aligns naturally with OASH's broader mandate of improving the nation's public health through policy, science, and prevention. It essentially serves as the operational arm for translating national health promotion priorities into concrete programs and resources, supporting the Assistant Secretaries for Health role as the top public health advisor to the HHS Secretary. Relevant to today's discussion, I'll speak to a few of our programs that relate specifically to nutrition. One way we do this is advancing nutrition guidance through the development and implementation of the Dietary Guidelines for Americans, which we develop in partnership with the U.S. Department of Agriculture. These guidelines shape school programs like school meals and food assistance that directly impact tribal communities. And this approach is closely connected to our Food is Medicine initiative, which has already been mentioned a few times. This is really where we see the key opportunity to recognize the access to nutritious, culturally relevant foods and that critical role in preventing and managing chronic disease. For tribal communities, this includes supporting traditional food systems, expanding access to locally sourced and indigenous foods, and integrating nutrition into healthcare and community programs. These efforts help address chronic conditions like diabetes and heart disease while reinforcing cultural practices that promote wellness. Together, these programs, along with some of our other key initiatives such as Healthy People and the Physical Activity Guidelines for Americans, provide a comprehensive, evidence-based foundation to advance nutrition, physical activity, and chronic disease prevention. Most importantly, these tools can be adapted and led by tribal communities to reflect their priorities, strengths, and traditions. We're committed to continuing this work in partnership with respect for tribal sovereignty and a shared goal of supporting healthier outcomes for current and future generations. Thanks for allowing me to be here today with you all.
Thank you. Vice President Musu.
Sorry, I wasn't tracking my comments here. Sorry, guys. Oh, go ahead. Yeah. Oh, okay. Yeah, this one. Yeah, I was writing it down for yesterday, or tomorrow, I'm so sorry. So we do want to thank Secretary Kennedy and the HHS leadership for your continued support of tribal nations and our health care needs. We recognize and appreciate the Secretary's genuine commitment to engaging tribal leaders. We are concerned with the focuses outlined here today. We're not initiated by tribal direction and were created without meaningful, proactive tribal consultation. We encourage the IHS leadership and staff to carefully review the working group's recommendations and remain actively engaged with tribal leaders and health experts. Pardon? Oh, I thought those were my comments, sorry. Skip me. Yeah, you're fine.
They might be the same comment for multiple sections. Yeah.
Yeah.
Just food sovereignty in general.
Yeah. No.
I didn't think you signed up for this.
No, mine was for tomorrow, but it's fine.
Okay, if we're good, sorry. My apologies. Chairman Green.
Thank you, Chairman. TJ Green, Chairman for the Makah Tribal Council. Want to thank all the tribal leaders for being here. Thank our federal partners as well for giving us this opportunity. I think on this issue, happy to hear the words "food is medicine." I think that's going to be the focus of my comments here. Appreciate some of the programs that are there, the demonstration projects, the pilot projects, where we're able to improve access to our traditional foods and our traditional medicines. That's a good step in the right direction, but we need to quickly move beyond that, in my opinion. We need to get to a place where our CMS, our billing over Medicare, Medicaid, can support these types of systems, these traditional systems that we have. Case in point, a lot of us have our own clinics. We have naturopaths in those clinics that give out supplements. We can bill for that. We should be able to do the same thing for our traditional foods. I'm in the Pacific Northwest. We got a great food sovereignty program. We provide halibut and salmon, and this guy raises chickens and provides fresh eggs to the community through that program at times, and it works. It's great. It's good, but it's not enough. It's not enough. We can, just back to that naturopath. I go see mine all the time, and I'm not taking statins because I go to the naturopath, and that's an important deal. We can do those things, but those are manufactured items, right? Those are manufactured items. They still are not the best for us. They're better than some of the other things, but they're not the best for us. Our traditional foods and being able to access that, out on the coast, all our fish, those omega-3 oils, that's all good stuff. That's all good for us. Another thing, I'm wrapped up here. I broke my thumb last week. I went to the ER. The doctor probably took one look at my health plan, and he's like, "Hey, you want any Vicodin for your pain?" Quick to offer me Vicodin. I said, "How about an ice pack? Give me an ice pack." But he's going to make some money off that. The system, that's the system we're in. And that's not right. And, we can do those things that hurt and harm our health. We can set up our billing and our reimbursement programs to pay for those sort of functions. And that's what we need to flip that upside down a bit. So I like what I've heard from the administration and wanting to do some of those things. I just want to be a little more bold about it. Thank you.
LeBlanc, please.
Yeah, so I would like to start by, actually the MAHA movement is one of the first things I can get behind as a tribal leader, because a lot of the initiatives are really important to our people and public health. I also want to recognize and support the many letters supporting tribes as nations and not DEI. This is long overdue, actually, and it's nice to have it in writing for the first time in a long time. Because it lifts up our voices, and unfortunately it pulls others down, but it puts us in the rightful place where we should have been from the beginning as a government-to-government relationship with the federal government and working directly with HHS. I mentioned this in our morning chat, and somebody had asked me about what it looks like to establish our food system. So I'm sure some other people will talk on some of the many great programs that are in existence, but I don't think they're one size fits all. There's too many restrictions and limited funding and fighting with each other to get those funds. I don't want to do that. Some tribes are large, some tribes have the infrastructure. Many tribes do not have the infrastructure to do that, but what we do have within our communities, and it is not prevalent, but it is growing, is the knowledge to reestablish and reinvigorate the food systems that have already been there in each of our regions. Each tribe here are specialists, whether they know it or not, in the food systems within their regions, because the tribes themselves survived off of this food system since time immemorial. And some of our tribes were nomadic. A lot of us had clan and familial systems to help take care of each other, to make sure there is enough food to go around through the harsh summer months, through the harsh winter months, so on and so forth. But the important thing is we knew how to navigate and manage our ecosystems and our environment. That was taken away from us when boarding schools happened, when forced relocation happened, when reservations happened. That was taken away, and no amount of money was ever put back in to cover those teachings, to put them back into our community. Everything was given by the federal government to take that stuff away from us, but nothing has been given really in context to give it back to us. So that's one of the main things that we need to focus on to make America healthy again, is that we are the leading knowledge keepers for our food systems, but they still need to be reestablished. I mean, our tribes are just now rediscovering some of our cultural roots. Like, for so long it was held down and kept quiet because of anti-Indian policy. Until 1978, we didn't even have the right to religious practice. So those things are being reestablished in our own communities still to this day, and now they're becoming more vibrant. That took, 50 years to do? So imagine the food systems, and if we really focused on them. So some suggestions, some recommendations, other than the existing programs that are already benefiting the tribes, SDPI, GWIC, TIPWIC, all of these other things that are very important, but they're also competitive. What I'm suggesting is, I already know that the MAHA movement is working with the USDA in conjunction because of the real foods and initiatives and things like that. So I'm suggesting establishing a tribal Department of Agriculture under HHS, not USDA, because again, food is medicine. You've all admitted it, and food within our ecosystem, within our own environment and our regionality is the most important way for all of us to survive, not just tribal people, but the people that are living in our area. Forever, farmers have been subsidized for foods that aren't even natural to the systems or foods that we normally would eat in most of our places. Whereas if you're subsidizing tribal farmers and tribal agriculture divisions, that would be a huge movement forward to the improving the health of our people, beyond just the medical portion, beyond just seeing a physician, but actually being at one with the earth, which we always believed in. 638, self-determination to manage our food systems, procurement processes, and trade. I often hear two of those things, but trade is left out, where we used to have trade routes and work with other tribes in conjunction. And we should have the ability to do that to however we want to do that through 638 contracting and compacting, similar to our healthcare systems. And then assistance in reclamation of traditional seeds, which increases food access, which will enhance gardens in each of our regions. Many of our tribes are already doing that. Our tribe has a robust program, but limited resources. And getting these out to people is a lot easier, it will be a lot better. So again, as always, like when you want somebody to have good nutrition, it's make it the easy choice, right? And the easy choice is the accessible choice. Food access as far as our traditional hunting, fishing, and gathering. Right now, for instance, we have commercial fishermen, they have to catch fish fresh off Lake Superior, and they drive it 2 hours to the nearest processing plant, only to drive it 3 hours back to distribute it across the Upper Peninsula in various locations. That's inefficient and not, we have the knowledge to take care of this food, but we have to bring it to this processing plant 2 hours away. It makes no sense to me that you're driving it back and forth, whereas a fisherman can catch it fresh out of the lake, cut it up, eat it, and we're good to go. A metal table is no healthier than a metal table here, And then investment in infrastructure. Tribes across the board need it. Again, many of this stuff was taken from us generation after generation after generation with very limited access to putting it back in place. We talked about 105L leasing for our health systems alone. That's just one option for our health systems, but what have we had to assist us in redevelopment of our agriculture and our traditional practices? Relatively nothing. If anything, the tribes have had to do the majority of investment into their own communities. And when our communities are thriving, so do the surrounding communities. And I think together, if we worked on that and looked at us as frontline farmers and managing our environment for our food systems, that the country as a whole, if you start with Native Americans, will be better and healthier. Miigwech.
Thank you. And just so everybody knows, I have about 7 in the queue right now. So I'm not ignoring you. All right? And I'm just going to go in order. And Chief Harris, I've seen your head come. So let's go with the governor first. Governor.
Thank you, Chairman. Governor James Naranjo from Santa Clara Pueblo. My comments will be short. I want to thank my brothers and sisters here at the table. In northern New Mexico, we're a very small tribe. And in order to feed our children and our seniors, we serve, in our early childhood, we serve over 500 meals a day. And our hands are tied because our school has to follow the USDA restrictions. We have cattle, we're traditional hunters, we're traditional farmers and gatherers. And just like my brother across the table, we're limited in our processing. And we know what's best for our children, we know best what's for our seniors, but yet our hands are tied because we have to follow USDA restrictions. We took over our own school from the BIE for that reason, so we can teach our language, because we're rich in our culture, our language, and our ways of life. We've been there from the time immemorial, and Pueblo law is different than urban law. And yet, we have outsiders, non-Indians, coming to our facilities because of the quality of food and just our ways of life, because we can't turn down anybody. That's just the way natives are. When people are hungry, they come to our facilities. When children are hungry, we go out of our way to supplement those meals through our own small budget that we have. And so, living close to the National Laboratory, it's unfortunate that they can provide billions of dollars for pit production, but yet we can't even provide money for a simple processing plant so that we don't have to follow the USDA restrictions. And it's unfortunate that we know what's best for our children, we know what's best for our seniors, we know what's best for our community, but throughout New Mexico, our hands are tied and our hands are strapped. But the power of prayer and our rich culture and religion gets us to where we're going to be. But we certainly have solutions to these questions and these answers. But I think it's important that you come and visit our respective reservations and our respective communities so you can actually see the fight that we're fighting. And this is an ongoing issue that we've been fighting for since time immemorial. And we're the unborn that our ancestors had prayed for. And we continue to pray for the ones that yet to come so that their quality of life is better. And living close to a laboratory and the destruction from these national laboratories, the quality of air and the quality of water is going to affect everybody across the country. And so these are some of the concerns that we have, because as being a part of the Accord tribes to Los Alamos, there's no respect for our ways of life. And without clean water that you can drink from the point of origin, you know, we suffer from 4 major fires that devastated 100% fish kill in our lands, and no help. And so, of course, protect the laboratory, but let our reservations burn and let our fish die. It's hurtful. But we're resilient, and that's why we're here today, so that we can bring our issues to the table and bring solutions to the table. Thank you. Kundawa.
Executive Director Yazzie.
Thank you. I come from where the pavement ends and the Wild West begins, the Navajo Nation. We are vast and large, 27,000 square miles across New Mexico, Arizona, Utah, and now some parts in Colorado. And I want to speak a little bit about the Special Diabetes Program and some of the recommendations we have. As my colleague has stated earlier, I want to echo the same concerns for this administration. And the first recommendation to improve effectiveness, continuity, and impact of our SDPI program-funded programs serving tribal communities is, number 1, allow no-cost extensions for future fiscal year greatness. Grantees to issue notices of grant award earlier in the fiscal year. We always get funded at the beginning of the new year, which is always puts the nation in a crisis mode. 3, increase funding for high need and growing populations, and that's critical, and I can have a separate meeting with that with you all. Moving on down with the Division of Long-Term Aging and Care Support Administration for our sacred, and that is our elders, those who have come before us, and that we are working hard to honor them. And one of the main issues and recommendation is, 1, to assess the current funding formula to ensure there's equitable distribution funding across all tribes, nation, and pueblos. I think the most important thing is to provide direct Title III funding to the nation and all nations. If not feasible, work with the states to limit or delete alerts for the fiscal year to avoid reversions. Provide one allocation that can adequately cover the entire fiscal year to reduce budget changes and last-minute expectations that often result in non-use funding. And confirm and attend tribal consultation with all tribe, nations, and pueblos to negotiate new Title III funding allocation based on current populations. It's really tough to work through states. The nation has to work on a outdated tri-state agreement with New Mexico, Arizona, and Utah, and this creates great difficulty in trying to get on every state's schedule to try to work an outdated tri-state agreement. So the nation is moving aggressively and would like to meet with regards to the tri-state agreement. We do have over 85 senior centers that are vast throughout the Navajo Nation, and we are in a food desert. I want to echo all the concerns and challenges that each of my colleagues has expressed here, and I really would like to invite each and every one of you to the nation so that you can see the challenges that we do face, and it's just not with just the food alone. We're dealing with transport. We would love to. We do our best in transporting food on a daily basis to all of our communities to all of our elders throughout the communities, while at the same time, a one-way trip to just even one elder is about 15 to 20 miles. And within a community of, for example, let's say Navajo Mountain, which is in a very, very remote area from the Navajo Nation's capital to Navajo Mountain, it's about a 5-hour drive to Navajo Mountain. So getting food to each of these locations is quite challenging. So then the Navajo Nation, in terms of finding fresh food, being in a food desert, it really drives the amount of funding that we have to use to get fresh foods to each of our communities, and even working with our local vendors to get foods to our elders at each of the 85 locations throughout the Navajo Nation. So those are the issues and concerns that I bring to your attention, and we look forward to working closely with you. Thank you.
Councilwoman Sawyer. Yes, ma'am.
Skip me for now.
Chairwoman Freese.
Good afternoon, everyone, or good morning. Thank you for joining us today. I really do appreciate you being here and listening to what we have to say when it comes to food sovereignty and food as medicine. I'm Herminia Frias, I'm Tribal Council for Pascuayaqui Tribe, and we literally live in a food desert. We live in the Sonoran Desert, and I want to thank you, Dr. Christensen, for visiting us. We are one of the tribes that have received the P4 pilot project funding, and we're doing what I feel is some amazing things with the P4 program. You know, we shared with Dr. Christensen and a lot of people from IHS, you know, what we're doing around our ranch and what we're doing around growing our own food and what we're doing with creating a micro market in the community so that people have access to fresh food. And the market is still in construction. We expect to open it at the end of the year. But part of that market is really the reintroducing our community, our citizens to our traditional food. So, you know, there's been a lot of reasons why people have not been able to continue with the foods that we traditionally eat. And a lot of it we talked about is affordability and accessibility. But a lot of our traditional foods, at least for us in the Sonoran Desert, are foods that have been foraged for time immemorial. And just last week, we hosted the Indigenous Data Sovereignty Conference. And at that conference, there were so many people from all over the world, all over the nations here, and that had never been to the Sonoran Desert. And one of the things that I love to do is I love to hike the Sonoran Desert. So I asked people, do you guys want to come and take a hike in the desert? It's not going to be anything stressful. It was 87 degrees, which for me is like so nice. It's perfect. And I even took someone the week before from CDC Consulting and took her out. She said, I thought you were going to cancel because it was 87 degrees. I'm like, are you kidding? This is perfect hiking weather, as long as you have water. And but one of the things that I shared with them is just to be out in the desert and to see the prickly pear, to see the saguaros, to see mesquite tree, creosote, to see what the desert has to offer, and to see that at that time when they were there, it's springtime, so the cacti were blooming. And so to see the cacti blooming and to be able to see that beneath that bloom of that flower is the fruit, and how that fruit is used to make, you know, juice and to make jam and to make a lot of different things that are very healthy for us. And to see the prickly pear and the nopales that we call, and how that food is prepared and how we continue to still eat that. But again, it's reintroducing that. And I feel like, you know, having everybody here at this table you are so vital, because we really look at things as a community. You know, there isn't a separation of, oh, this is CDC money, and this is SAMHSA money, and this is ACL money, and, you know, FDA. we as tribes, we always have to be as resourceful and as efficient as we possibly can when it comes to our resources. And so when we are working with our FDIPA program and we're working with our SNAP program and administrators are thinking, well, we can't use them at the same time. And then we're looking at our P4 program and we're looking at, all of these different, our GWIC program. How is it that we can utilize these in the best way that really help us? I've shared in the past in these meetings and other meetings about how important it is to have a model like the 477 model that focuses on training and education around HHS. Having a model that allows us to look at all of the different divisions, departments, centers that are focusing on food as medicine and use it together for us to implement it in a self-governance type of way. So at the end of the end goal is really using food as medicine and all of these implications and positive implications that it has when it comes to our health, when it comes to our nutrition, and including mental health. There was discussion here I heard with the schools. That's so important. How do we include our schools? How do we include our elders? How do we include, the entire community? So I think that there's a lot of great things that can be done by having all of you sitting here at the table and sitting with us here at the table, and how can we create self-governance type of models so that we're not doing what the accountants should be doing, figuring out where it should be going, but really looking at the big picture of how are our people becoming healthier? How are we helping our people be healthy? How are we creating opportunities for them to access food that has traditionally been part of our diet, that has fed us, that has sustained us, and the affordability around that. And I also just want to share that with our micro market, I really am looking forward to how we use this learning kitchen that I talked about as reintroducing, because I have a lot of cool young people in my life, and they're all foodies. And so they're always on TikTok and they're looking at different ways that people are preparing food. And a lot of that foodie stuff is coming from Korea, because it's fascination with the Korean culture and how they prepare all this food. And there's nothing that, and I think there's an opportunity for us to look at that foodie lifestyle with our own ancestral food, the food that we forage, the food that's been hunted, the food that has been gathered, and to really think about this for our young people as this, staying with the times and looking at their foodie lifestyles. How can they start looking at foods and all the nutrition that's around that, the different colors of the food and the taste and their palate, to really get them early in their life so that they can be healthy eaters for a lifetime. So thank you for listening to me.
I'm ready, if I'm able to speak.
Okay.
Sorry. Brooke Sawyer from the Macaw Tribe. To build off what everyone's been saying on traditional foods, I know we've been trying to introduce whale back into our dietary needs that have been around for centuries that we have not been able to utilize as much as we need to. I'd say since we live in the rural area where we're at, we have one grocery store also, and we have to travel really far to go to get anything, go to Costco or Walmart or anything. So having all of our traditional foods and having gardens and having the freezers to hold our meats and everything is something that we truly need. And the lack of access to whole foods is tied to elevated rates of type 2 diabetes, obesity, heart disease, and certain types of cancer. And that's something we also need help with, is with our epidemiology, to find out where the cancer is coming from, how we can do better with all of our foods. Thank you.
Chairman Allen.
Thanks, Mr. Chair. Well, a lot of great points are being made today regarding the importance of traditional foods as a part of the medicine with regard to enhancing and advancing the health of Indian country. I do. Are you the FDA? So one of the questions that I have is whether or not FDA can identify traditional foods as one of our medicines, because we feel that it is part of what's making, helping us become healthier, if you will. And so it's a question that should be raised, because if the administration is embracing the fact that traditional foods is a part of helping our communities be healthy, based on all the points that has been made this morning, there should be a way to recognize it as a part of medicine that helps restore healthy living styles. So that's one of the points that I want to ask and get some feedback on it, and or what do we need to do to make that happen? Because a part of it is how we get reimbursed as we're moving traditional health care moving into our systems. Then we want to be able to get reimbursed for those kinds of activities that are part of our healthy programs systems. But I also want to raise, everybody raised the issue of different kinds of healthy foods that we produce in our respective regions, and how that needs to be enhanced. It just seems to me that you guys should be advocating to the Secretary that he needs to join forces with Secretary of Agriculture, Rollins, to talk about agriculture and what's their role in contributing to this challenge, to enhance healthy living styles. Vice Chair talked about, the transportation in the Great Lakes, getting to and from processing plants. We have similar challenges in the Northwest with salmon, halibut, shellfish, etc. So is that a responsibility of HHS? Not exactly, but it is responsibility of agriculture. So there should be some partnership going on here. And a lot of times, when we get into these conversations, we go, well, wait a minute, there's another department over here that has resources that should be collaborating with HHS on these matters, because agriculture and including maritime agriculture is a big deal to us and an opportunity. So those are resources that we would always ask and say, well, is HHS going to pony up some resources, get the checkbook out? Well, quite frankly, we just talked to your budget assistant secretary. We don't see it there's not a line item there, right? But over at agriculture, there is. And so that should be a part of the solution. So on the one hand, we want to know that does HHS and FDA agree that it is part of the solution? So we've said to the Secretary countless times, Indian country wants America to be healthy again. We are not the problem. We are a big part of the solution. We are in rural America. And if rural America is not healthy, then America is not healthy. And so there's lots to the solutions here with regard to this matter. And so I would just throw those comments out to complement my colleagues here regarding how do we move the needle of infusing traditional foods and traditional medicines into the mix of what we're trying to accomplish. Like with the aging programs, a big part of our programs, I think Lonnie, my tribe's vice chair, noted that we have community gardens. And we got a ton of our volunteers. And I bet you that's true in most of our communities where they're managed mostly by volunteers. But it can't be all volunteers because you need resources in order to be able to manage. It's not just small gardens, large gardens, because we've got fairly large communities. So I would just throw those comments out, observations, to see what kind of feedback we'll get.
Chief Harris.
Thank you. Chief Harris Katami Nation, also Nashville area representative of USET, which is the United Southern Eastern Tribes, and we have a few remarks that we would like to make. And so as I make them, be a couple suggestions as I go through these. So though our health disparities are due to a plethora of issues, including chronic underfunding, USET agrees with and support the administration's position that the access to quality, nutritious, affordable health care and food and healthy eating habits as a part of achieving better outcomes in any country. So we definitely support that. In general, in pursuit of its goal of fostering better eating habits in any country, we urge the administration to focus on access and affordability, as you've heard here throughout the morning session. Tribal nations are well aware of the need to bring more fresh produce and healthy proteins to our communities. We also share in the administration's belief that local control and oversight of programs and services foster better outcomes. And as such, we support those policies as well. In addition, for example, we urge the IHS and HHS to advocate alongside the U.S. Department of Agriculture for expansion of Public Law 93-638, which is the 638 Self-Determination Authority for tribal nations to administer the Supplemental Nutrition Assistance Program, which is referred to as SNAP. Also, in addition, tribal self-governance over SNAP will also support we also support the administration's goals of streamlining federal functions and ensuring that federal dollars are spent appropriately to address the priorities of our communities by empowering tribal nations to assume full management of our own nutritional programs under the SNAP. Another potential avenue for increasing access to healthy quality food in Indian country is expansion of the IHS Produce Prescription Pilot Program, P4. And as you should know, the P4 was created in 2022. And moving along in conclusion, nutritional education, more specifically, this is referring to diabetes. Nutrition education and access to healthy foods are often critical to preventing chronic diseases such and as recognized as diabetes. The Special Diabetes Program for Indians, SDPI, is a critical resource for nutrition education in Indian country and has been proven successful in reducing diabetes prevalence and severity in tribal communities. Better nutrition in tribal communities is a goal for both tribal nations and administration. And increased resource for nutrition-related activities through the SDPI would support this shared priority. HHS should advocate with Congress for increased funding, permanent reauthorization for the program, and self-government authorities for tribal nations to administer our own STPI programs. Thank you.
Ms. Bunch.
Thank you, Mr. Chairman. And Corey Bunch here from Cherokee Nation. Thank you for joining us today in your time. Thank you to the other tribal leaders. There's an old saying that says an ounce of prevention is worth a pound of cure. And I might alter that a bit and say an ounce of prevention is worth 2 pounds of cure in Indian country. As you know, American Indians and Alaskan Natives are 50% more likely to face obesity challenges than the general U.S. population. We've got to put more resources into prevention, it sounds like to me. At the Cherokee Nation, we've had great success, but it's been a challenge, and food is medicine. We've constructed a meat processing facility, and we've been able to take advantage of federal grants across multiple agencies to provide over 1 million pounds of locally sourced meat for SNAP participants through our food distribution programs, and we've also been able to provide community organizations with this meat. It's grown locally. That not only supports local ranchers and farmers, but it creates more jobs across the Cherokee Nation. But if we had more resources, we could definitely put them towards prevention efforts. One of the things that we've done is also constructed wellness centers and paid for by our third-party revenues, our third-party health revenues. These are essentially hubs for communities who did not have a place to go to choose healthy lifestyles like walking and working out and yoga classes and volleyball for elders. and healthy living classrooms or healthy cooking classrooms in these facilities. The challenge is we need more of them. Our reservation's 7,000 square miles, and we haven't been able to construct as many as are needed. But in a location, for instance, in Adair County, Stillwell, my hometown in the Cherokee Nation, where a wellness center once did not exist, a 50,000 square foot wellness center exists. Now we have 500 and 600 people a day coming into the wellness center and making themselves, they're making the right choices to be healthy. We just need more resources. So again, I urge you to expand the grants and the P4 activities and just provide more resources. We have the capacity to do it. We want to do it. We just need more resources. Thank you, Mr. Chairman.
Vice Chairman.
Thank you, Chair. Thank you to our HHS representatives who are here. I just wanted to speak again to a couple more programs. Since we have folks that are sitting right here, I can speak a couple of notes here to ACF and ACL specifically, because that's where my job duties lie most. So I apologize, IHS and OASH. I haven't worked as intimately with your programs yet, but I'm sure there's some good programs out there. For CCDF, Head Start, and the Title VI programs specifically, at Jamestown, while we don't have a Head Start program, we do have our two sister tribes that are bookending us do have Head Start programs, and so I do know that they are involved in making sure that traditional foods are part of Head Start, which is great. I would say that CCDF and the Title VI program specifically that Jamestown does use, I will say positively that those programs in particular, I do find more flexibility than others, and so I'm grateful for that. You'll hear us tribes always asking for more and greater flexibility, and that includes how we are reporting as well. The reporting burden, the administrative burdens on smaller tribes such as myself, small staff, multiple hats. We are always wanting to take our time out of doing reporting and data and putting our time into the direct services and getting those meals out the door to our kids and our elders. So if there is an area where I want to see more flexibility, it's allowing us to put our budget funds toward those direct services and lessening the data burden. And I know that that is a goal of this administration, is figuring out how do we make things more efficient. So having conversations on the sides with tribes and with the Tribal Advisory Committee will be a great avenue for that, where we can tell you exactly what is the data burden, what is the administrative burden. But I at least wanted to say that I am supportive of what is here, but also more. So wanted to thank you for that. One of the things that I also want to bring up is within CCDF specifically, because of the child care fiasco that seemed to happen that did not have anything to do with tribes, it is now burdening tribes with Defend the Spend. And I know, Kim, you and I have talked about this before. I am concerned that Defend the Spend is going to leak into other programs of HHS. And I don't know how many other HHS programs are under Defend the Spend right now, but because child care hit the media, I see why it happened, but it wasn't tribes who created that problem. And Defend the Spend was extra reporting that was laid on us without tribal consultation. So I am worried that Defend the Spend is going to be doing the opposite goal, where we're going to be spending budgeted time of hours doing more reports than we are getting real food out to our communities. So I want to make sure I put that on the table. I also want to, me and Chairman Allen, we had the same wavelength going about FDA. I wanted to ask about that too, so thank you, Chair Allen, for asking that. But I also want to support that there should be a partnership with the USDA, because tribes can be part of a bigger solution that just doesn't affect our tribal communities. Washington State specifically is going through an agricultural crisis. Agriculture in Washington State is decreasing because of all of the different pressures that are happening to our farmers. And I love our local food. We use some of our funding, especially for our food bank, to purchase from our local farmers who are non-tribal, but we have this close relationship in our community. So we're getting healthy foods, not only from our own fishermen and harvesters, but from our local farmers, our non-Indigenous farmers as well. It's a good local food that our bodies still need. And so we can be a part of the solution of not just using our funding for our own community, but creating the greater community, making that healthy again through healthy economy, healthy eating, sharing of resources. So I wanted to put that holistic approach out there too, that when When Secretary Kennedy and Congress and the President are investing in Indian country, it's investing in all of America, not just Indian country America. Thank you.
Councilmember Cutts.
Yeah, yes, I think when we talk about the things that we have to do around food, there's some things that I think that we need to look at. We want to make sure that traditional foods are part of our food distribution program that's authorized for that, and I think we've been working on that, and I think we can do better. We need to consider self-governance options in some of this food resource funding that's out there. And I will tell you, we're going to have to reach out further than just within HHS. In one of my rivers, Cowlitz River, named after the Cowlitz tribe, we have smelt listed as endangered. I can't stick a net in that river. I can't stick a net in that river. There's more people trying to rescue than there are people trying to stick a net in the river. And so you hear about us being stewards of the land and the water, our foods. We have pressures on that are way beyond our tribal members, and we can't even access those. And so I don't know what the answers are, but many of the things that are foods and medicines are scarce resources that are being endangered by the non-native population in our communities. And so we need the government's assistance in securing some of those sources.
I, for one, really appreciated this discussion. Oh, we got one more, please.
Thank you, Mr. Chairman. I'll make my real short and sweet, but when you said non-native is affecting our local areas, my name's Deidre Carlisle. I'm from the Auction Indian community, which is a small rural community in Arizona, southern Arizona. Now, some may not that have been out to auction, because there's a city of Maricopa that back in 2000 only had maybe 5,000 people. Now they have 80,000 plus. So we've seen a lot of development. But in our case, when we talk about traditional foods, and I liked when you started off, ma'am, with we want to hear all sources. Ron, you kind of touched about partnerships. So I just want to make this awareness about, we have 4 washes that run through our reservation. We are dealing with growth. We are dealing with data centers. We are dealing with other facilities that are building near the boundaries of our reservation, which means we need clean water. We're a farming community, about 23,000, our reservation is 23,000 acres. We farm about 16,000. But that aside, if you could put a bug in the ears of any of your federal partners that deal with data centers or outside construction, operations, man-made waste, man-made emissions going through our washes does in fact affect our traditional food, the plants out there. We have wild spinach, we call evuk, that's out there. We have the greasewood, which we call shugai in our language. If those are contaminated, just using those examples because of man-made emissions going through the washes, or, that would affect the efforts of our people trying to go back to the use of traditional foods because they would be contaminated. And the greasewood, shugai bush, my Autumn relatives are here, they do know that that's used as a way of, they always said boiling that and drinking it as tea was a way to help diabetes. I don't think it was ever proven, but it was always, we think it is, or it's another way. But like our wild spinach, it's out there, so how can we teach our young ones to go out and look for wild spinach when it could be contaminated because of the emissions of the different going through our washes. So I just wanted to bring that up. If you have any, whether it's Department of Agriculture, EPA, any, put a bug into your friend, your other partners, your agency partners with that. And again, I support everything that was said by the tribal leaders today as well. So thank you.
Councilwoman Cobb.
Bonjour, good morning. I appreciate you allowing me to speak here today. It's an honor, but like my relative said here to my left, the food is medicine is much more bigger than DHS. You throw that pebble into the pond that says food is medicine, and it ripples out into EPA. It ripples out into, we mentioned the non-tribal, is when we go back, it's our spearing time this year, and we have to close down our reservation lakes to the non-tribal because we're protecting the fish, and it's the overfishing of the non-tribal. It's the bringing of the barges that the non-tribal use to put in their pier systems, or building boat launches without input from the tribe, so that the dialogue begins locally. Yes, the dialogue here is great, but it's bigger than, when we talk about the food sovereignty issue, it is greater than us sitting in this room. It's all other departments encompassing. And I'd like to see, perhaps next year an add-on to include those departments when we're talking about issues like this, because we can fix and we can put our piece of the puzzle together. It's incomplete without those other departments. And, so that circle then would be incomplete because we can only go so far. But miigwech.
Okay. I want to thank everybody for their input. I was listening to everybody and their comments, and I was looking at the title, Real Food in Indian Country. And what does that mean to me? All I know is our food. That's all I know. And when I think about our food isn't as available to us as it was to just my grandmother's generation. We have a 2,000-mile river that many of our tribes sit on in Alaska that has no fish in it anymore, that we can't rely on. We have a moose population that has dwindled in size because of overhunting or lack of predator control. And that means all the other animals that rely on these games are having problems too. And so what we're seeing more and more is those predators coming into our communities to get a food source from those communities where they feared to go in before. So wolves and bears are now coming into our community. And where we're having to look at how we're going to protect our property and our children. And so we constantly are more on the lookout now. So when I think about our food and think about it as a whole, it's so entwined with our well-being, who we are, how we do things, why did we do things. Our uncles don't get to teach their nephews how to go out and set beaver traps as much anymore. Our uncles don't get to teach them to go out and catch a moose all the time. So when we think about the things that our uncles can't do, and we think about the young men that don't learn those things that let them know who they are as a people, what happens? we see the results on a very negative end. And that's tied to either high alcoholism or even sometimes suicide, and too much suicide. We need to look at real foods, our food, as the most important point of keeping our people going. Hearing barriers between agencies doesn't solve that problem. We got to knock them down. Work collectively. Work with each tribal member here, because our foods are a little bit different, but they're all the same. So that we can really be addressing how our foods impact our people, not just in dietary needs. So I just wanted to say that, and I support all the comments that was shared here. But when we're talking about our foods, it's bigger. And I wanted to share that. Sir, you had a comment you wanted to make?
Hey, Guadalupe Castaneda from the Makah tribe. So the Makah people have always understood that real food is medicine. And, you know, I really like this team here at HHS. And for us, whale, halibut, salmon, and other, you know, traditional foods have always been medicine for us, and culture, and it's community health. And I just had a couple questions. One for Eric with the FDA on your commitment to working with us on the nutritional value of our whale, and then also if it's regulatory changes, can the Secretary work on it with tribes? And if there needs to be a statutory change, we can work with it with our legislators, and they can work with us to make those changes as well. And those were just my two quick ones after listening to everybody. So, thank you.
Thank you. We'd like to give the panelists the opportunity to say closing remarks, please.
Well, I think I got the most questions out of all of you. So one, I'd love just to follow up with you guys afterwards. Just a few quick key points. I think one of the things that I would like to sort of share with all of you is that FDA, again, you guys we need to talk more. I'll be honest. We actually do have some grants out there and a lot of training that is available around food safety practices that is free. So please, again, just reach out to us and we can help provide those trainings and things of that nature. In regards to working with other agencies, we work closely with USDA. We meet with them on a daily basis. The regulations in the United States around food is very complex, and there are places where USDA regulates it and we regulate it, and there's products in between that we both regulate. So we just know that we are working closely with them. With all these additional things, looking at chemicals in foods, we are working very closely with EPA. So we are from the food standpoint, it really, when you guys said it touches everything, it truly touches everything, and I could not agree more with you. Really, in sort of building on all these things, I think one of the bigger things that I want to press upon is, and you guys are talking about this, is really sort of an integrated system. We all can't do this alone. We all need each other and really sort of build up and sort of leverage each other and any resources we possibly have. So really, you know, just think about that as we, the FDA, are a resource for you. So please reach out, and very excited to have more discussions, regulatory or otherwise, in any way we can help you. So thank you. Thank you for the time.
Principal Deputy Cabal.
Thank you. Just want to reinforce that we recognize that tribes are best positioned to determine what works for your communities. It is a privilege to listen and to learn from your guidance. Your input is essential in ensuring our work with tribes reflect your priorities and leads to meaningful, lasting improvements in health and well-being of tribal children, families, and communities. And advancing real food in Indian country means advancing food sovereignty and cultural knowledge and long-term health and self-determination. And as a bow hunter, I look forward to coming and visiting you at your invitation and participating, helping contribute to your community as well. Thank you.
Chief Medical Officer Christensen.
Yes, thank you all. This all was very, very meaningful and resonant to me. I'm happy to say through the support of the Secretary, Mr. Cruz, we are going to expand the P4P program. And I think it's very vital because it's a program that is yours. Our job is to support, answer questions, whatever you need. And we see in all of our 5 projects a different approach, and it's working for that community as it should. And I hope we can continue to provide that type of support and backup for you as you develop what is your right to be sovereign, in including your food, your customs, your waterways, your hunting, your gathering. Everything that way needs to be that. So I know that the IHS is committed to supporting this in all realms. We look forward to continued engagement and conversation with you, but know that, and I'll just personally say that food is medicine has always been very important to me in all aspects, and that's where it all came from in the first place. There is no remedy, there's no medicine, there's no anything that wasn't a plant, a tree, a flower that was discovered by our ancestors. And so I enthusiastically support you and will do anything we can to help you with your program. So thank you so much for sharing today, really. Thank you.
Principal Deputy Lazar.
Thank you as well. I appreciate hearing from all of you. It's been very informational to me. The word halibut and salmon has come up so often. I'm like, okay, I'm going to come to everybody who has halibut, that's for sure. But we will make sure that we do get out for more site visits. I appreciate hearing about making sure we're assessing our formulas for distribution of funds. The schedule of funds distribution is often relative to when the funds are appropriated to us, and what we do take pride in, so that you know, as soon as funds are appropriated to us, we distribute them immediately within shorter time frames than we ever have before. So we will continue to do that. The micro market is a very interesting idea to hear about, where we can scale and share that with others. We would be happy to do that. I think that I also picked up a great idea about our young Native Americans and elders working together to talk on TikTok and other places about growing food, eating in community and so forth, using that as a great model. We also heard more about the senior centers and how we can address funding more of them. Flexibility, it's good to hear flexibility is appreciated. This is a topic that Carrie Benson, who's our Deputy Assistant Secretary for Aging, is here. This is a topic we talk about all the time, is where can we find more flexibility in the Older Americans Act, particularly Title VI. We'll continue to do so and work with you on that. When you talk about defend the spend, all of us, so there's not just some of us, all of us are involved in defend the spend, but let me reinforce to you why that is important. Because when you hear about finding fraud and abuse, 9 billion, 20 billion, or whatever, what does that do? It creates opportunities for us to put that funding where it should be going. So when we do take the time to defend the spend and look at fraud, waste, and abuse, we're finding opportunities for that money to be redirected. And that's just one of the reasons why it's important for us to do so. I would like to mention also malnutrition is very important. I know we didn't talk about it. We talked about food as medicine. Malnutrition is so common in our elders, and we don't recognize it as much as we need to, because we talk about calories and not nutrition. So nutrition-dense food is important. When you talk about your food, I know we're talking about nutrient-dense food, and that's what's particularly important to us. Lastly, I would like to say that we will soon be announcing a new director for our Native American office, which we're very excited and will give us an opportunity to get out more and learn more from you, and appreciate all that I heard today. Thank you very much.
Acting Director Pearson.
Sure. I'll echo the sentiments of the other panelists, but just really wanted to say thank you for everyone's time. It was really informative to hear the stories and what does real food mean to you all and your communities, how you've really utilized food as medicine, and how important it is to really tailor that to the different populations, and really how creative you all have been to make this work for your communities. But definitely hearing about the need for more resources and more support and more flexibility to be able to do this in the ways that work for you all. So just appreciate your time.
Thank you. And I just want to, in closing here, to say a thanks to Senator Kennedy. He came to Tanana, and we were looking at how do we get more fresh produce into our community, knowing that our store has stopped selling any produce at all. And there was an old greenhouse that they were able to locate some money to help us get that greenhouse back to active. And so in Alaska, we're looking at getting this greenhouse operational in Tanana that's going to be able to provide produce to us 9 months out of the year, where our growing season's only like 3 months. And so that's going to be something really cool. I just wanted to mention that. I wanted to thank Mark for helping locate the money. But so that was a good collective effort, starting from the tribe, moving up through administration with the highest level of support. That being said, I do want to thank the panelists for being here today. I want to thank all the tribal leaders for all your energy and comments. And we're going to be breaking for lunch now. And then there's going to be one-on-one tribal meetings, if you have them scheduled, from 12:30 to 5. And so this basically concludes our time today. And enjoy your meetings and have a good afternoon. Basi.
Produced by the U.S. Department of Health and Human Services.